Dr Fareed Nad, Professor Dr Awazariman, Professor Dr Inayat, and Dr Assanil Khan, with the faculty of Department of Public Health, Professor Dr Karim, Dr Samira, Dr Nita, and the rest of the organizing committee. Our students, good morning. I would like to extend a very warm welcome to all of you, particularly our esteemed speakers. This two-day international conference is the first international conference that the Faculty of Life Sciences has organized. The Department of Public Health is actually established not so long ago at SZABIST by the esteemed guidance of our Chancellor, Dr. Awazariman, and we established this department with an aim to be the top-notch in the region, to be the best, and Alhamdulillah, with all the support provided by Madam Shahnaz and our Vice Presidents, Dr. Al-Afwati, Madam Nasreen, we have achieved that aim. It's not a claim, it's a reality that the program that we are running in the Department of Public Health, which is Master of Science in Public Health, is simply the best program in the region that we are offering. This conference is primarily to provide a platform to our students to have a highly valuable interaction with the experts in the field, particularly in public health. And inshallah, during the course of this session, I believe that our student will have an unmatched experience of learning and understanding the core issues of public health. With that, I would again welcome all the participants and speakers, and hopefully you will have a wonderful learning experience during this session. Thank you so much.
Thank you, sir. I am very obliged to introduce the President SZABIST, Madam Shahnaz Wazir. Madam Shahnaz has served as the Executive Director of Pakistan Center of Philanthropy and also has the privilege of serving as an advisor to the Prime Minister of Yusuf Raza Gilani on social sector. Madam Shahnaz was awarded Cesarean in 2016 for her services to education. She has an illustrious career as an educationist, development policy specialist, and a well-known women's rights activist. She served at World Bank, held the position of Minister of State for Education, Government of Pakistan. She is on board of a number of prestigious national and international organizations, trusts, advisories, councils, and educational boards. Madam Shahnaz has a wealth of expertise on education, health, women development, population, and poverty alleviation. She has worked studiously for numerous social causes such as women's rights and polio eradication in Pakistan. Her long-term commitment to education provision for children of low-income families is reflected by her contribution as a trustee to Education Trust Nasra Schools in Karachi. Currently, she is a provincial coordinator for the government of Sindh for all primary healthcare programs, including maternal and child health and family planning programs. At this auspicious occasion, I feel privileged to welcome our President, Madam Shahnaz Wazir, on stage and honor us with her inspiring words.
Bismillahirrahmanirrahim. Dr. Kashif Ali, Dean Life Sciences and Public Health. Our very, very distinguished panel, we are very pleased to welcome you here this morning on the second day of the first International Conference on Life Sciences. Dr. Karim, who is going to be chairing the session today. Dr. Professor Fareed Nad, who is a known policy advocate in particular, as well as a researcher, and a highly acknowledged specialist in the field of population, demographics, and family planning. Dr. Professor Awazariman, it's a privilege to have you here. I think soon. Dr. Inayat, really nice to see you here again. Dr. Assanil Khan, also a very distinguished advisor on the Health Policy Ministry of National Health Services and Coordination. Dr. Samira Rizvi, thank you very much for coordinating this entire organizing the panels and all the background work along with you, all the other faculty. And very, very importantly to my students, Assalamu alaikum and a very good morning. For me, today is a very, very special day because I think that the International Conference on Life Sciences, so excellently organized by our Life Sciences Department and the Dean and the faculty, brings together a cross-sectorality, an intersectorality between the sciences, and which we heard a lot about yesterday. We had an excellent session, and for those who, some of the students I think here today who were here yesterday, but some are those who were not here yesterday, I was really very impressed with the sessions that we had on molecular biology, on epidemiology, on microbiology and immunology. And I learned a great deal from the specialists who spoke, bio-nanotechnology, bioinformatics, forensic science, various other areas that we had specialists speak on. And today we will be hearing about public health issues pertaining to the lives of mothers and children, the lives of the citizens of Pakistan, and in particular about family planning, population demographics, which Dr. Karim, I think, has spent his life researching. So we have here today really an outstanding panel, and I'm sure that our students are really going to benefit a lot and learn a lot from it. So I just want to take a few minutes and share with you why and how I got involved in the whole area of public health. Because by professional qualifications, basically I'm an educationist. And this goes a long time back, right into the late 70s and early 80s, 1980s. The country at that time, after Mr. Bhutto's illegal and unconstitutional removal from power in 1977, and there was a dictatorship in the country. And during that time, and those of you, of course, who are studying Pakistan history must have gone through that period, the dictatorship came out with a lot of laws which we felt was totally anti-democratic, and in particular against the rights of women. And some of us who actively participated in the movement for the restoration of democracy began to study these areas about the rights of women. And central to the right of women was the right to health, was the right to a safe environment within which they could assume productive lives, safe and healthy lives as young girls, as children, as young girls, and then as women and as mothers. And why is health so central? Because health really is the pivot upon which each individual person's life is connected so closely. If you do not have good health and a good healthy lifestyle, and if you do not have access to good public health services, it affects everything else in your life. You can't function as a professional, you can't function as a student, you can't function in your normal course of life, and as a child, it affects the cognitive development of children. So when we started talking about the rights of people, we realized how central the right to a healthy, safe, and productive life was. And in Pakistan, we know that we still face many, many challenges. And from the 80s, despite the difficulties, I think somewhere this agenda has found its way. And when this agenda arrived prominently, right in the policy forums, this agenda meaning the health agenda, the public health agenda, the lives of citizens, the health of Pakistan, It is the health of the nation. The health of the nation determines everything else. It determines its productivity. So this agenda of education, health, and the right to education and the right to health arrived in the policy forums of the government of Pakistan in the late 1980s. And it really arrived when Mohtarama Benazir Bhutto assumed the position of Prime Minister. And she took very significant steps to see that public health systems reached out to the people, to those people who lived out in the villages, in remote areas, and that's how the Lady Health Workers Program was born. And all my colleagues sitting here know a great deal about it. The Lady Health Workers Program is a program that started in 1993, actually, formally, but the discussion on it and the design of the program and the advocacy for the program and the policy formulations around that program took place before 1993. And the idea was that if you can put a woman in every village, take a woman from every village and skill her, train her, educate her with the basic competencies for primary and promotive health care, and she can deal with the issues of primary health care in the village, the lives of the villagers everywhere in Pakistan would be positively affected. So this was a large program. We started with 10,000 lady health workers, and then it continued to 20,000, and every single government, regardless of which government, they have all supported it. And it's one of the central things in the health sector. So hopefully you hear a little bit about it. But why else was it important? And it was actually called the Family Planning and Primary Health Care Program. It was not just called the Primary Health Care Program, but Family Planning and Primary Health, because family planning is central to the health of a nation. The demographics of Pakistan show that we are one of the highest population growth rate countries in the world. Our resources are limited, our population is exploding, our cities are crowded, we don't have good housing arrangement, we don't have good transportation systems, we don't have sufficient schools, we don't have good schools, we don't have sufficient hospitals and clinics, and so many other things that the citizens of Pakistan need. So population, its impact, its dynamics, its consequences, and its implications, which are not just personal, not just social, but they're economic as well. And that's what Pakistan is facing today as well. A huge economic crisis, because we are growing so rapidly, and our population is increasing and multiplying so rapidly, that it is difficult for any government to come and do any serious or consistent planning. You make a plan, and before you know it, your population growth rate is so high, your GDP is not as high, and your population growth rate is almost outstripping the GDP. So for those of you who are interested in economics, this is relevant. For those of you who are interested in the rights, this is a relevant topic. For those of you who are interested in the sciences, this is important. For those of you who are interested in sociology, this is important. And climate change, and water, in infrastructure, any aspect of social, economic life of Pakistan, issues of public health are central. And so are the issues equally central within that entire paradigm, the issues of family planning, population, and demography. And I would like to take this opportunity to say to each and every one of my students sitting here, please do think about pursuing your studies further in the area of demography in particular, because Pakistan has very few demographers, really just a handful of demographers, and Pakistan has just a handful of health economists. And this is something I frequently suggest to the students. If you want a really good profession to pursue, look at health economics. Because there are political implications for almost everything, every sector and every domain. But the political and economy around demography. There is a political economy around demography, and that's what you can study. If I had a choice to go back, sometimes people ask me, what would you do? And I definitely say that I would go back and probably do health economics, become a public health economist, because policy and public health and the economy are very closely linked. And these are the connections. I'm sure you'll make those. You're a new generation, you're bright and smart. And today is a wonderful day for you to learn a great deal from, honestly, some of the most outstanding people in Pakistan. So I'd like to welcome our distinguished panel here again, and look forward keenly to hearing your views and comments on where we are today and what are the implications for Pakistan on public health issues. Thank you very much, Dr. Kashif Ali and Samira, for organizing this.
Thank you, Madam, for such an inspiring speech and providing us an opportunity to gain from your knowledge and wisdom. It is an occasion which has given us the opportunity to test our knowledge and understanding on a very dynamic and a broad topic, situation regarding poverty and health issues in Pakistan and other Muslim countries. The session will be opened by Professor Dr. Karim, a well-known demographer. He has a PhD in demography and human development from Cornell University, USA. He worked with the United Nations and World Bank, later served as a professor and research scholar at various universities. He was a professor and head of reproductive health program at Assanil University, Karachi, and research associate, senior research fellow at London School of Economics in UK and Princeton University, Johns Hopkins University in US. At present, he is a professor in Department of Public Health at SZABIST and distinguished senior fellow in School of Public Policy at George Mason University, USA. Dr. Karim has co-authored or co-edited 3 books on Islam, the State, and Population, Future of the Global Muslim Population, and Migration in Pakistan. Besides, he has also co-authored and authored over 60 research articles on population, health, and development issues in Pakistan and other South Asian and Muslim countries. He has presented in international conferences as a speaker at multiple universities in North America, Europe, North Africa, West and Central Asia, South and Southeast Asia, and Australia. We will begin this session by inviting the chairperson, Professor Dr. Karim, to share a few thoughts. Sir, please.
Bismillah ar-Rahman ar-Rahim. Madam Shahnaz Wazir Ali, Dr. Kashif Ali, distinguished panelists, colleagues, and students. Is it okay? I'm not making a presentation, just following on what Madam Shahnaz already has mentioned about issues related to population and how it has linkages with poverty. And that's what I'm going to show a few slides before our other panelists come in. Please, okay. First of all, we are lucky to be living in urban areas, but if you can see that poverty is chronic in Pakistan, especially in rural areas. We started with about 30% of the population living in poverty in the 1980s, and in rural areas it has remained as high as before, almost close to 31% of the population, this is Planning Commission data, are living under poverty. And you could imagine that poverty in rural areas is really, really terrible. Of course, situation has changed in urban areas or where poverty is declining, but rural areas are about close to 65% of our population lives. That's the situation which is very, very alarming. As a demographer, I think that it has linkages with the way our population is growing, about which Madam Shahnaz Wazir Ali has already mentioned. And if I get an opportunity, I think there is another, when we are talking about in the second session, I'm going to talk about the situation in Pakistan vis-a-vis other, as compared to other Muslim countries. But this background, why poverty is so prevalent in Pakistan, as a demographer, also as someone who does work in public policy, I think it has to do with the way the population is growing. The next slide, please, DG. Okay, as you could see, that this is the average number of children born per woman in Pakistan. As you could see from 1990s, on average, about 5 children were born per woman in rural areas, and it has remained high, about 4 per woman. Why these numbers are important, and even in urban areas it's about 3. Why these numbers are important? That if in a country on average, if a woman has 2 children, that means that she is replacing herself and her husband. That means the population in those countries are not growing much. We will talk about that when we talk about in the presentations on Bangladesh, Iran, and Indonesia, that they have there, on average, the number of children born per woman is 2. And so you can imagine that our population are almost doubling, more than twice every year. In that background, if you look at, and you can see that how poverty, growing population breeds poverty. Next slide, please. Okay. And as you could see, that was an average, about 4 children per woman in rural areas and 3 in urban areas. If you look at the wealth index, which is the way to calculate how people are, their poorest to the richest, as you could see, those who are poorest, they have on average 5 children. So what it means that if there are more children growing, that means there's more poverty, especially if there is the family which has more children. So there are about more than 5 children per woman, and in the poorest segment of the population, and among the richest group is 2.7. Even among those who are wealthy, the average number of children is still more than 2. So you could imagine that how things are for those who are poorer, which have more people to take care of, more children rather, about 5 on average, in addition to other family members, as compared to about 2.5 among those who are. What does 2.5 and 5.2 means basically? It's an average. So those who know about it, they could imagine, but just think of it as something like 10 women having about 50 children. So you could imagine each household having 5 children. Next, please. As another issue which we come to is the infant mortality. Infant mortality is something, or under 5 mortality is something that on average how many children are born in a family and how many die. As you could see that the lowest group, the poorest, have on average about 76 out of 1,000, or say 8% of the children, they never reach their first birthday. And about 10% or 100 out of 1,000, they never reach 5 years of age. As compared to that, you can see that in the highest group, the wealthiest, is about half. So those who are poorer not only have more children, but they are also dying. And these are the issues which we need to address. Okay? Anything else? I don't think so. Okay, that's it. Now, the reason I introduced this issue, that this is very, very important for us to look at, that are we able to reach out to those who are poorer? Then of course, there are not only issues related to economic well-being, there's also issues related to their health, as I mentioned about in the infant and under 5 mortality. And these issues are going to be discussed by our 4 prominent panelists. I'm going to not announce their names because they have to be introduced by our Nita. Dr. Nita, please.
Thank you, sir, for sharing vital information and profound knowledge. It gives me an honor to welcome our first invited speaker, Professor Dr. Fareed Nad. Dr. Fareed Nad is a medical doctor having advanced training in public health from Columbia University and demography from Johns Hopkins University, USA. He started his career as a rural medical officer in Gawada, Balochistan. He has since then worked as a population and health expert at Khan University, Asia Foundation, Population Council, Japago, as well as at Qasim University, Saudi Arabia. In 2000, he founded the Safe Motherhood Alliance Pakistan, which helped in developing national strategy of maternal, neonatal, and child health, and country's first national MNCH program. He also served as an advisor for Pakistan's first national survey in Pakistan Maternal Mortality Survey 2019. Dr. Fareed is currently working as a professor of public health at Health Services Academy, University, Islamabad. I would like to invite Professor Dr. Fareed Nad to the podium and share your expert opinion on poverty and maternal health indicators in Pakistan.
जी सर स्लाइड कर सकते हैं
Thank you. نحمده ونصلي على رسوله الكريم. بسم الله الرحمن الرحيم. Very good morning and thank you for inviting me. I think I will start by the title actually is something which I was told that I should use the latest survey which we have in maternal mortality, sir, you told me, and relate the findings with poverty. So the whole presentation is about that, and I will introduce the survey itself was called Pakistan Maternal Mortality Survey. It was actually the first one ever done in Pakistan on an exclusive basis. Before that, in 2006, 2007, I don't know if you know that we do have demographic and health surveys pretty much like every 5 to 10 years in Pakistan. And we have had 4 so far, and the last one, the one before last was 2006-07, which also estimated maternal mortality, okay? And I'll explain what maternal mortality is so you know what I'm talking about. This was a big survey, and actually they went on into 136,000 households all over the country, including GB and AJK. And the entire sample was actually asked about what were the deaths during the last 3 years. And so they identified maternal deaths from that inquiry, okay? So basically when they asked whether when they were told that there was a death of a woman, adult woman in the household in the last 3 years, another team went back to that household and conducted what was called a verbal autopsy, okay? There were about 1,100 such deaths, about 1,200, and they were investigated to see if it was that female death was indeed a maternal death or not, okay? And out of the sample, about 10% of the households, they asked questions to the women who had a pregnancy during the last 3 years, surviving women who survived a pregnancy in the last 3 years. And they asked very many questions about like where they went, what they used and all that. So this will be an interesting data. I think it's a lot of numbers, but hopefully, I'll be able to explain what it's all about, okay? And so first I'll start with maternal mortality. The maternal mortality ratio is here, which basically you take the number of maternal deaths and divide it by the total number of live births and multiply it by 100,000. Why 100,000? Because fortunately there are very few deaths who are called maternal. So 100,000 constant will actually give a reasonable number to look at. What is a maternal death? It's a death of a woman who dies during pregnancy or childbirth or postpartum period within 42 days due to any causes related with pregnancy or its management, any complications. So not from accidental or incidental causes. So if a woman dies in a car accident and she's pregnant, that's not considered a maternal death, otherwise, So maternal mortality ratio, what actually tells you, it tells you that how a society is dealing with their mothers. If a woman dies during pregnancy and childbirth, I ask my students what should be the ideal MMR, maternal mortality ratio, and I hope you have the answer. It should be 0, right? No mother should die during pregnancy or while bringing a life into this world. So basically, it actually tells you that what health services are available to the women, what is the status of the women in the society, and what kind of complications they can have because of poverty, because of So this MMR actually right now you're seeing 2 bars here, and the central number is the actual point estimate. So the good news is that the maternal mortality ratio in 2006 it was 276, okay, and in 2019 it went down to 186. The other 2 numbers are confidence intervals, which means that we are dealing with a sample. So what we are saying here is that in 2019 we estimated the maternal mortality ratio was 186. 186 mothers dying during pregnancy or childbirth or postpartum period out of every 100,000 live births, okay? But this number could have ranged between 138 and 234, okay? And that's basically what it's telling you. So it means that if you look here, the higher level of 234 in the 2019 and the lower level is 234 in 2006, it means that these 2 numbers are significantly different from each other. So the decline from 276 to 186 is significant statistically, okay? It's true, it's real, okay? That's what we're saying. So that's the good news. The other good news is that this is 2006 only, and excluding AJK and GB, the difference is between urban and rural. So apply the same formula from the last one, okay? If you see the 2 urban and rural confidence intervals, they do not overlap, which means that the rural area has 320 women dying out of 100,000, and urban area 177. And the difference between these 2 was significant statistically. This was a real, true difference, So much more women are dying in the rural areas who are poor than in the urban areas. In 2019, this actually changed. So the urban came from 177 to 157, not much of a decline. But from in the rural area, it came down from 325 to 185. So it's a significant decline, okay? So this is the part of the good news. Unfortunately, that's where the good news ends. Most of the rest of the presentation is probably not. Here is another way to look at the risk of maternal death. This is called an odds ratio, okay? What is an odds ratio? You look at a reference which is basically right here is the highest quintile. There are 5 quintiles of wealth in the population, okay, in the survey sample, and the highest is Q5, which means they are the richest people in our sample, and Q1 is the lowest, which is the poorest people in the sample. So what is telling you this point estimate is that the women who are in the poorest quintile, they were 4 times more likely to die than the richest quintile. 4 times more likely. So basically, that's a very, very high risk. And similarly, those who are in the middle 3 quintiles, which are middle class women, so to speak, they were about 3 times more likely to die than these women who are the richest. Okay? So that's what odds ratio is telling you. Next is the same thing for education. So if you compare the women who have like under metric education with those who have 10 class or above, So secondary education, I think, is a very significant kind of like indicator. Education actually doesn't matter if the woman doesn't, if somebody doesn't have 10th grade or above, okay? So below 10th grade is no education, education is the same thing. So these are the women who have up to 9th grade, and they also include illiterate women, no schooling women. They were 2.4 times more likely to die than those who had 10th class of education or above, okay? That's what it's telling you. And then we have another one, which is households' average schooling and maternal risk of dying. And it's basically, out of the all the adults, 15 plus actually, 15 plus members of the household, what is the average schooling of those? And again, if you compare it, you see about twice more likely to die. Those households where very few members are educated, they are twice more, the women in those households are twice more likely to die. Okay? So, and if you compare urban and rural, about the same thing, 1.6 and 1.4 times more likely to die. The rural women are again like, 1.4 times more likely to die than the urban women. Okay, so this was maternal mortality, and then there's another indicator which is called perinatal mortality. What is that? If a child is born and dies within 6 days of birth, like not completing 1 week, that's called an early neonatal death. And there are some children, infants, who are born dead. They are called stillbirths. If you put them together and divide it by the total number of live births, then it will give you the perinatal mortality rate. Why is it important? It has the same risk factors as the maternal mortality. Okay? So basically, 5 minutes. Oh, I have. Okay, so I'll go through like quickly, and this is like the perinatal mortality per 1,000 live births, and only in all the regions you see the overall was 70 per 1,000, and in GB it was significantly lower than others. Okay, so this is by wealth quintile, and you see here, this is what I want to show you anyway, that the highest wealth quintile has the lowest perinatal mortality of 45 per 1,000. While the poorest have 94 almost, So the difference is very significant between the rich and the poor. Then we have, these are basically the same odds ratios which telling you that the lowest quintile are twice more likely to die than the highest quintile, And again, more or less the same thing as this is education level, and again you see that the women who have 10th grade or higher, they have significantly lower perinatal mortality than the one who have no education at all. And similarly, this is odds ratio, okay? And this is by household head of level and household heads level of education, and this also is the same thing. Then this is not significant anyway, so this is interesting, which I think Dr. Mehta will give you maybe 5 more minutes, because I'm bringing in interesting data here. This is about induced abortion, okay? So this is the first time that a direct question was asked about induced abortion. Why women have abortions? Because they don't want a child, okay? And they become pregnant unwantedly, okay? And that why it happens? Usually because, they're not using a family planning method, or their family planning method failed. So basically, they will go for abortions. The majority of the women who go for an induced abortion in Pakistan are married, have multiple children, and they go for an abortion with their husband's consent. Okay, that's what we know about it already. So what we asked, when we ask a direct question, women usually don't answer. So not every woman who has had an abortion will tell you. Very few will tell you. So there's not a direct method which we can apply here as a rate, abortion rate, because the number who told us that they had an abortion was very few. But we were able to compare their risk factors. So if you look at this, again is the odds ratio which I explained, that if you take the lowest quintile, which is the poorest women, as a reference category, the highest quintile, the richest women are 5.5 times more likely to have an induced abortion. That's interesting, right? So basically, the women who have the resources to approach a hospital, go to a hospital and get an abortion, induced abortion, they are more likely to have an induced abortion. And similarly for the education, basically this is the adjusted odds ratio for, okay, so I think I'll skip this one, but basically saying that, the educated women are also more likely to have abortions. And this is about households' average education. And that's what basically the information there was that the women who have access to resources are richer, are more educated, more likely to go for an abortion. Cesarean section rates are usually, they should range between 5 to 15%. The cesarean section is when, cut the woman and get the baby out, because otherwise the baby won't come out. It's, for some reason, it's either sideways or it's like malposition. The woman have had weakened and she cannot push the baby out naturally. So cesarean section is that. Cesarean section is a luxury, so you can't have like everywhere. And as you can see here, these are the rates for rural, 17.5 Pakistan, and 34, almost double, actually double in the urban areas. Then you look at the schooling, and you see that those women who have any schooling, they have 28% cesarean section rate, compared to those who have no schooling, only 9%. And this is the quintile, wealth quintile thing again. The poorest women have 6%, the richest women have 38%. So that's something which, now what it is telling you that the women who need cesarean section, even they cannot have it if they are poor. Basically, that's what it's telling you. And here is, why actually cesarean section happens, because let's take the diabetes in pregnancy. When the woman has diabetes in pregnancy, the baby is bigger and it's difficult to get out, and that's why they need a cesarean section. So those women who have a diabetes in pregnancy, they were about 3 times more likely to have a cesarean section. But that's adjusted for, of wealth quintile and education. So even after you adjust for control for education and residence and schooling, this is the number you get. So what it's telling you is that even if a woman was diabetic and had to have cesarean section, she might not have it if she was poor or uneducated. Okay. Then is the service utilization, and this is the last part. I think what we know for Pakistan is that antenatal care is almost universal. If you ask a woman, did you see a doctor during pregnancy, she will say yes. Okay, almost 90% of them say yes. Okay. But that's not like you don't go to a doctor just to say hello to him or her. You have to have all these things. So we defined it as an ideal in antenatal care, where the woman saw a skilled provider at least 4 visits. The first visit in the first 3 months of pregnancy, she had some blood and urine tests done. Her blood pressure was taken. She was advised for iron tablets, and she was given a TT injection. Okay. So this was only 20.5%. Only 21% of women actually had the ideal antenatal care, the good antenatal care. And this was again, in provinces, if you see, Balochistan had the lowest proportion and AJK had the highest proportion. And if you look at by residence, again, there's a difference between urban and rural. And if you look at the education, again, this is the difference. And if you look at the wealth quintiles, again, the poorest have only 3%, and the richest had about 47%, So the women who are the poorest, they are very, very less likely, almost 0 have an ideal antenatal care. Similarly, skilled birth attendant is defined as the baby delivered by a trained provider, like a doctor, a midwife, or a lady health visitor, not a traditional birth attendant or a DAY. And this rate was also lowest in Balochistan and highest in AJK. And this rate was also, related with the, the education, and also with poverty. So the poorest women have only 46% had skilled birth attendant, and the richest women about 90%. Okay, so compared to that, about twice that number. And I'll skip these slides because again these are the same defining this. So summary is here that women who are poor and uneducated and living in rural areas are at a significantly higher risk of maternal and perinatal mortality. And these women are also less likely to receive quality maternal health services, including antenatal care, skilled birth attendance, and cesarean sections. Okay? On the other hand, the women living in urban areas and those belonging to higher socioeconomic strata are more likely to receive quality maternal health services, including ideal antenatal care, skilled birth attendance, and cesarean section. And then the third thing is that richer and urban women, or educated women, are more likely to access the health services for an induced abortion compared to the poor and the rural women. Okay? Thank you so much. Okay. So if there are any questions, I can.
Ji, Assalamu alaikum. My name is Dr. Bilal Siddiqui, Faculty of Public Health, SZABIST. Sir, very well conducted MMS. My query is that number one, why mothers or their caretakers, they do not take and are not very much serious in accessing the healthcare services, especially in antenatal care during the delivery or around after the pregnancy, in terms of any postnatal depression or any other complications.
Why didn't they what? Sorry?
They usually, we have seen that they sometimes they not to prefer, probably they don't have a trust on the health system or other certain domains or determinants. So have we, do you think that this is a predominantly area we need to explore, that health behavior and what determinants we need to explore?
Yeah.
And
So
intervene?
trust comes from experience, okay? If I'm a poor woman, I always put myself in their shoes to think how it feels, and if I'm a poor woman and I go to a doctor, even a free doctor, a free medical dispensary of the government, they will not treat me well. They will not respect me. They will ask me to sit for long hours, I have left my children at home. I have so many things to do at home. It's hot. I have walked about a mile, 2 miles, Why would I go, So that's where, it actually lies. If you look at those things, if you don't build the trust, there will be no trust. And so they would rather go to a traditional birth attendant who is like next door. She's not going to charge too much, and she's also going to be very helpful, friendly, So that's, I think, the reason, in my view.
Sir, my name is Dr. Vivek, and currently I'm working in the Health Department, Government of Sindh, and I'm the alumni of this institute, batch 4.
Sure.
So I'm also working as a child specialist, working with the Pakistan Pediatric Association. So good to know that a team of Assanil Khan is over here at the SZABIST from Islamabad. So sir, बात सिर्फ इतनी पूछनी है कि जब भी हम पीडियाट्रिक के किसी कॉन्फ्रेंस पे बैठते हैं तो पहली स्लाइड यही आती है कि पाकिस्तान इज द मोस्ट डेंजरस कंट्रीज फॉर द वुमन फॉर चाइल्ड बर्थ. Despite having a multiple symposium from the pediatric, from the policy making, from the government side, from the others, we are always on the lost in the international forums. What do you think would we have to politicize at the national or the provincial level for improving such indicators? Since a decade long, if we go for the Human Developmental Index, we have not so much literacy rate in grown figures. So what do you think sitting at this
I'll tell you my experience. Ma'am Shahnaz has already talked about lady health workers. I think it is the single most powerful decision to bring lady health workers, to help rural women, poor rural women. It was like inspired by the barefoot doctors in China and all that, because the poor women, as I said, they do not and they cannot go to facilities, and so if you want to provide them quality care at their doorstep, lady health workers was, it actually brought a revolution, In the 1990s when it was started, the World Bank and I think the agencies had actually opposed this phenomena, this idea, but it was brought by, the then government, anyway. And if you look at the DHS between 1991 and 2007, there is a decline, in fertility. There is an increase in family planning. There is an increase in maternal and child health indicators. And that's because of the lead health workers. So here was one bright example of political will to help women in the rural areas. I don't think there is any more than that after that. I'm really sorry to say, but now even the lead health work program has become like bureaucratic. It's actually, in last it's like zeal and quality. Madam would remember, it was like that. So it's kind of an emotional answer. But I think that's unfortunate that we do not respect our women, as simple as that. Yes, ma'am.
Assalamu alaikum. Thank you for the nice presentation. I am Khadija Abed, Faculty of Life Sciences Department. Sir, I wanted to ask, there is a very interesting factor that cesarean section is high among educated women and high quantiles. So what is the reason behind that?
So cesarean section can also be elective. Women can choose to have cesarean section rather than like going through a normal delivery for various reasons, because it's fixed, like you can get a date. It's painless, and it's also it saves you from lots of like trouble. So, and that's why I think women do go for cesarean section. In general, I think if you look at, I didn't show you the data, but in private hospitals, the cesarean section rates are higher, almost double than the public sector hospitals. One reason could be that even if it's a small thing which can be managed without a cesarean section, probably the hospital will decide to go for a cesarean section because it pays more money, so I think unfortunately that's the case.
Thank you, sir.
Yeah. Yes, ma'am.
Thank you, Fareed. I tend to differ a bit, and this has been studied in so many countries that the cesarean section is related to the profit motive by the private practitioners. And this is a fact, and this has been done, and a lot of research has been done. The private practitioners are doing left and right and doing the cesarean section. Yes, there may be a wish, but then the richer actually, when they see and the doctor saying, okay, look here, if you don't get operation, your wife will die, your child will die, the rich will decide to go ahead. So, I would actually do that.
Agreed.
Yeah, actually, I would support Dr. Thawer. And personal experience, I have, worked at, well-known facility here, hospital. The personal experience is that my daughter, she was expecting a few years ago, and so she went to one of the well-known hospitals, not Aga Khan. And the doctor asked her, and well-known gynecologist, and the doctor asked her that, what does your husband do? She said that he works for a multinational, and so, okay, so this is a good candidate.
He was asking, do you have the money? And she said,
yeah, and she said, oh, okay, listen, my experience, the doctor says that my experience is that those children who are born C-section, they usually get admitted at Karachi Grammar School. So if you want your child to go to Karachi Grammar School, and she said, no, I don't want to come. So she said, Daddy, I don't want to go back to her again. Yeah. So that's this is
no, that's what we found.
And I have known only low-income women, those people who have, female workers at their home. I know that at least I have experienced that 2 or 3 of them during the past 5 years. They had their children, daughters who have been recently married, they have gone through C-section, and because they know that these women can also get money from anywhere they want. And usually they do. Somebody comes up, 35,000. In one case, I'm telling you, it was 125,000 rupees for a C-section operation. Delivery. So that's something which is to be looked at.
Yeah, we did actually, we found that the private sector hospitals actually are doing twice more cesarean sections than the public sector. We found that, yeah.
But on the other hand, going to public sector hospitals, it's a miracle, it's terrible. That's much worse.
Dr. Fareed Nad, just a comment here to, I think, make the links between what happens at a personal decision-making level or the doctor's advice, is that where is the regulatory framework? What about standards? What about the public health system, which is really the responsibility of the government, establishing standards and then having those standards implemented. Because we know in Pakistan that by and large, hospitals, private hospitals particularly, either there are outstanding hospitals like the Aga Khan, and there are some in Lahore and some in Islamabad, but by and large the private sector medical caregiving practices are not really regulated well. And it's very difficult to do that because Pakistan is a huge country. You can perhaps inform us how many gynecologists there would be, how many obstetricians there would be, how many clinics there are where women go for delivery. Tens of thousands, hundreds of thousands. It's very difficult to have a regulatory framework. And the healthcare commissions which have been established, which I think some of our students may have heard of institutional arrangements. There's a healthcare commission in Sindh also. And its responsibility is to ensure that the right practices, the correct medical, ethical practices are followed. But it's very difficult. It's just, I don't know, there are many factors in our society through which behavior is influenced. So a very simple question is that you go onto the streets and in the traffic, people don't observe traffic rules. They don't observe sometimes the red light. And similarly, in very sophisticated and complicated types of services, such as medical care services, regulation is a big issue. I hope we can hear a little bit about that from you, from the government of
Just
Pakistan.
my experience in the last presentation I made, I actually gave this information that private sector hospitals are doing twice at the cesarean section than public sector. There were women doctors from the Society of Obstetrics and Gynecology in Pakistan. They vehemently opposed me. They said, no, it's not, doesn't happen. You know, we are professionals. A professional society like, you know, SOGP, they have the responsibility, you know, not just the healthcare commission. So basically, I think in developed countries like USA, I've seen that, you know, these professional bodies, they actually regulate their own professions, and they should. Unfortunately, not happening in Pakistan. So, thank you. Thank you so much.
Thank you very much, sir, for your valuable information, discussion, and elucidating the current situation of Pakistan. It will definitely help us in future. Our second invited speaker, Professor Dr Awazariman, is a meritorious professor, former chairman psychiatry, director of medical education at Dow University of Health Sciences, ex-executive director of A.Q. Khan Institute of Behavioral Sciences. As a medical educationist, he is a pioneer in designing and starting multiple teaching activities at different institutions. He is an honorary international fellow of American Psychiatric Association and recipient of Lifetime Achievement Award by Pakistan Psychiatric Society and contribution to services for promotion of mental health services in Pakistan. He has many more than 100 research in his credit and is a member of Sindh Mental Health Authority, ex-member Executive Committee of Pakistan Psychiatric Society. Dr. Awazariman also served as a chairman academics and research at Karwani Hayat and was awarded Best University Teacher Award by HEC in 2014. Currently, Dr. Raza is supervising community-based National Psychiatric Morbidity Survey of Pakistan and is the principal of Hamdard College of Medicine and Dentistry. I would like to invite Professor Dr. Awazariman on stage for elaborating the topic.
Thank you very much, Dr. Mehtab, Karim, and organizers to invite me to talk about these important issues. Before this, it was being talked that about poverty, about maternal mental health. You talk about any negative thing, and that negative thing have a strong association with mental health. So what is basically mental health? And today, Dr. Mehtab have asked me to share about the results of that survey that we are conducting in Pakistan. But before going to that, if you look at the Agenda 2030. What is the Agenda 2030? It is basically United Nations General Assembly in 2015 decided that set up 17 interlinked global goals that are famously known as Sustainable Development Goal for achieving better and sustainable future by 2030. And these are the 17 different goals that have set by United Nations General Assembly. If you look at those goals, at number 3 is basically it's good. नहीं कर रहा ना. Okay. So if you look at the number 3 goal, that is basically related to good health and well-being. And what is well-being? Well-being is basically equal to mental health. And if you look at that, this is basically the topic of this plenary session, that is healthcare and mental health. And if you want that, what is health? What is the definition of health by WHO? And health is not merely the absence of disease. It is complete, not only the physical but social and mental well-being. So mental well-being is an important integral part of health, definition of health by WHO. And if you want to know and if you want to assess that how many of us are mentally healthy, you have to assess yourself on these 4 parameters. And these are the 4 parameters which determine whether an individual is healthy or not. The first parameter is that person, if he realizes his potentials, that how many potentials he has, then he is mentally healthy. If he is not realizing his potential, he is not mentally healthy. Second thing, he copes with the normal stressors of the life. If you are able to cope with your daily routine life hassles, then you are mentally healthy. If you are unable to do that, you are not mentally healthy. Then you work, whatever you do, work productively. And not only this productively, this should be something which contribute to the community. And these are basically 4 parameters on the basis of which we determine whether we are healthy or not. And if you look at the data from Pakistan, it's not, okay. What is the state of mental health in Pakistan? If you look at that, this is the prevalence of anxiety and depression. This is one of the articles that published in British Journal of Psychiatry. And if you look at that article, that in Pakistan, the prevalence is 25 to 60% in female and 10 to 25% in male. While this is worldwide, this is, and in Pakistan, this is 3 to 5 times more than what is in the world. So this is a state of mental health in our country. And there are multiple reasons for that, and these multiple reasons basically they are associated with the other global indicators that include sustainable cities, economic conditions, poverty, peace and justice, galloping price, and these all other sustainable goals, they are strongly associated with this mental state of Pakistan. Second thing, there is a lack of psychiatrists in Pakistan. There is scarcity of mental health professionals in Pakistan. I will get a chance to present in Sydney, and they invited me to talk about the issues of psychiatry, mental health in Pakistan. So at that time I gathered the data that how many psychiatrists are working in Pakistan. So at that time, when I gathered the data, there were 500 psychiatrists basically they are working in Pakistan, and all are not qualified. I included the practitioner, after including there were 500, but then I talked to one of my colleagues in USA that how many psychiatrists they are in USA. So he told me that we are 800 Pakistani psychiatrists who are working in USA. I talked to my another colleague who is the president of British Pakistani Psychiatric Association, that how many psychiatrists you are in UK. He said that we are 700. In 2 countries there are 1500 Pakistani psychiatrists, and all of them are qualified. While in Pakistan we have just 500, and most of them are not qualified, they are practicing psychiatrists. So this is a state, and not only that, if you compare the ratio to the population, this is basically half than our neighboring countries. So if you compare, not with the developing country, even with India, the ratio is half than that of India. So this is a state. Second thing, It is a hard fact that most of the practitioners, they are practicing in big cities, while most of our population is basically residing in the rural areas. But the state of health is not very good in big cities like Karachi. In a population of 22 million population, Karachi, 2.5 million psychiatric patients and only 17 trained psychiatrists and few, if any, trained psychiatric nurse to take care of approximately 600 psychiatric beds in city of Karachi. So situation even in cities is not very good. And this is another thing, that is the lack of awareness that people don't have, and these are the places where most of these patients are going to land up. And these are not at some hidden places, these are very prominent. If you go to a Sadar in front of Railway, you will find Bade Hakim Saab, and he is going to, and if you see that most of the patients, they are basically suffering from the psychiatric illnesses. And you see most of these shrines, you see these places, and you find a lot of mental health patients basically on these places, and this is because they are not aware of that. And state level challenges to mental health, this is one of the very important component. The state is not very, the condition is not very good at a state level. According to Human Rights Commission report of 2018, no proper mental health policies exist in Pakistan, and lack of political will to invest in mental health to convince the stakeholders. So because of this, to convince the stakeholders, there is a need to design, and to design a policy, there is a need to have a proper data. So what we did to get that data, we decided to have a survey, and that is, for that survey, we selected the community-based survey, and Karim is basically us in this group where we are conducting this survey. I'm briefly talk about that survey, how we are doing that. And the second thing, that we do not select hospital-based survey, we select the community-based survey. What is the reason why we select that? Because in hospital, most of the severe patients, they are only going to be hospitalized. So you cannot get a data of those majority of the patient in the community because they are not visiting hospitals. So hospital-based data will not reflect them. So what we decide to go into the community and get a data from the community. And we, most of these patients who are suffering basically from the minor psychiatric problems, and that psychiatric problems basically having effect on their decision making, on their quality of life, and that is not being assessed. So that's why we selected that hospital-based survey. Then another issue, that who is going to conduct this survey? There is a lack of specialists who cannot do that. So what we did, we selected a tool which is known as layman interview tools, and these are the tools basically being used in most of the developed countries. And in these tools, you don't need experts. And these tools basically are conducted by the training graduates, and we are going to train them. And even in USA, these tools are being used. This is a list of the tools that we searched, and ultimately we selected one of that tools, that is mini international neuropsychiatric interview tool. This is a tool that is basically having assessed the 17 disorder. And what we did, that we got permission from David Sheehan. He gave permission to use it, and we just translated this. This is the one interview which consists of 45 pages, and this is the one interview that we are going to have with one patient. And so every patient is going, and this is have an skipping mechanism, and through skipping, the most of the things are going to skip, but this is a proper interview that is being done internationally all over the world. But even up to date, none of such type of survey has been done. And we got permission from National Ethical Board and from our institutional board of the Doyle University of Health Sciences. After that, we basically have a challenge of sampling, that how we get the sample. So what we did, that we approached Pakistan Bureau of Statistics, and they provide us that sampling, and that sampling is, you see that this is a sample that have been calculated from all over the country. And ultimately we decided to have an interview of 22,360 households and one person from each household. Next. This is basically sampling is a three-stage sampling. In the first stage, the Pakistan Bureau of Statistics have divided all of the population into the blocks. They have very good system, and these blocks are known as enumeration blocks. And each block consists of 200 to 250 households. So basically, they have selected these blocks on their own from whole of the country, and we go to the blocks and they have assigned a person who was accompanying us as we are going to these blocks in the rural area and in the urban areas. And when we reach each block, then each block there was a second stage, which house to be selected. So there is a method that randomly we select the first house, and after that first house we skip and interview every 20 house. So in this way we are going to complete that block. And when we reach a house, then is the third stage of randomly selecting a person. So initially, these are the blocks basically which are being given to us, Pakistan Bureau of Statistics. Next, when we reach the household, when we reach the house, when we reach the household, which individual to be interviewed from that household. So initially what we decided to interview the person whose date of birth is the closest to our date of visit to that house. But we got a lot of criticism from international reviewers, and they said that you don't do that, and you do attempt a kish method for selecting that individual from that household. And in this method, basically, we organize the family member according to their age, and then we randomly select from, and later on we realize this is the correct method, because in our rural area, none of the people, they are knowing their date of birth, but they know that this is the elder one, this is the younger one. So in this way, we selected those things. Next. So household, basically we selected the individual on de facto basis, and this household comprises of the people who are sharing the same kitchen. If someone is living away from their de jure position, then he will be counted at the place where he is living. But the household servants, because they are sharing the same kitchen, so they were the part of that household. And according to the Pakistan Demographic Survey of 2007, one household basically in Pakistan consists of 6.6 individuals. Next. So data analysis, I'm briefly going to share with you the data. And this data is basically, we have not still published. The survey is still in process. We have completed the data of 5,680 households in Sindh. And we completed almost all areas except few areas in Shikarpur. Because of law and order situation, we do not go to 2 blocks in Shikarpur. Otherwise, we have completed that. And this is a data of, this is unpublished data. Our survey, we have completed Punjab, but we have completed half of the KPK and Balochistan, and this is going to be completed within next 2 or 3 months. And this is the data, the major depression and all the illnesses. It is a brief idea, you can get an idea about that. Next. So if you look at the socioeconomic condition and look at the anxiety and depression, gathered only 2 disorders, you will see a strong correlation of this disorder with the socioeconomic condition of those individuals. Although no one can be spared from the mental illnesses, even the higher strata, even the lower strata, but comparatively, because hardships, life hardships are more in lower socioeconomic stress, so this anxiety and depression is more common in those families. So now, if you look at that, the previous anecdotal reports, they are showing that the prevalence of mental health disorder is 3 to 5 times more than the world. But after our data, you see that it is not more. This is almost same as in the world. This is the important finding that I'm sharing with you, and when we'll publish it, then we will be able to work on it. So this survey will help in achieving universal health initiatives that is being set by UNO in 2050, and that ensure that everyone have access to the quality mental health services without financial restraints. And what will happen if you improve the mental health of the society? that chronicity will be avoided and making life healthier and richer and lived with dignity. And we are talking about the dignity, and dignity is directly related to your mental health. So greater financial returns will be expected after that because of increased productivity and decreased cost of illness. Overall, individual and communities will be made conflict and stress resilient in their daily life and quality life, which most of the complaint we are making, that we are, less tolerant, and these all things have got direct correlation with them. Even with the decision in previous, question answer session, it was being asked about the decision making. So decision making is one of the important component, one of the cognitive skill that is directly related to your mental health. So in background of COVID pandemic, there is a demand of increased mental health support to address the high psychological and mental impact. So investment in mental health need to be prioritized within the context of COVID-19, and investment can be done by increasing resilience of the individuals who rediscover themselves and their communities to be responsive due to the lockdown. So these are a few things that we have, and this is the data that we have shared, and I think the forum is open for questions if you have any questions.
Thank you, sir, for the nice presentation. Sir, I wanted to ask that you said that in Pakistan we have 500 psychiatrists, but Pakistani psychiatrists are serving in the West. There are 1,500 Pakistani psychiatrists there.
Two countries.
Two countries.
Not all the world, yes.
So why we are not serving our country? We prefer to go out and serve there.
You better understand that. I think this is because of the financial restraints, because of the most of the thing, everyone want a better living. And people qualified over here, and they get, those people got a better opportunity. I got a lot of better opportunities, and people definitely go for that.
So this is not the lack of health system, or?
No. This is basically once you qualify. Once you qualified, you hunt for the better opportunities. And most of those better opportunities come from abroad and not over here. So this is the reason, because of that, the people are shifting from here. वो जब डॉक्टर बनते हैं सब कहते हैं कि खिदमत करनी है मुल्क की, जब बन जाते हैं तो फिर सही पता चलता है.
Assalamu alaikum, sir. So this is Nabina Fatma, currently enrolled in MS-PH program at SZABIST. Sir, you have talked about the diagnosis basically through the survey. What are the preventive strategies being taken into consideration in declining the mental health disorder rate in Pakistan and to retain the qualified psychiatrists in Pakistan?
The qualified, retaining the qualified psychiatrist is an big issue the government can do for that, and that is beyond our ability. But what we can do, we can improve the resilience in our society, the tolerance in our society. There are a lot of things that can be done for them. For example, I usually preach for that, adopt a healthy lifestyle. Wake early in the morning, follow the nature. So what is the nature? What is the time of awakening? When the sun is rising. So what we are following, most of us are waking 10, 12 o'clock. So this is basically having a negative impact. I have done supervise and fill students. And what we do is that we give medicine to few people and we just advise exercise. And BDNF is a brain-derived neurotropic factor that increases in both. So when you start doing exercise, your brain starts secreting chemicals, and those chemicals basically having regenerative purposes. So when you are healthy, you have no mental illness, your stress resilience is going to improve. There is a lot of things that you have to avoid, which usually I advise that this is the bad thing in your life. Avoid it as much as possible. Emitted blue rays, when you use it most of the time in the night time, that have an effect on your mental health. Second thing, it is going to impact your patience. When this was a 1G, you wait for 2 or 3 minutes. Then it becomes 3G, you wait for 3 minutes, then it becomes 2G, you wait for 2 minutes. Now after 1G, you wait for 1 or 2 seconds, and when that website is not opening, what you are going to do? You shift to other. So that's basically what this is going to do is your life, your patience is going to remove from your life. वो जो कहते हैं ना सबर का फल मीठा होता है, वो सबर आपकी जिंदगी से खत्म हो रहा है because of this. So avoid this. Second thing, you have a communication with a colleague, communication with a friend, talking with each other had a lot of impact on your mental health. But what you are doing that you are messaging. You see that a lot of, whenever you message, you see that lot of, how many likes I got this on day. There is a disorder I used to say that is a selfitis. This is a disorder. You just take a selfie and then you, waiting for the responses. And you say, I have 400 likes. And you got in, you say कि अब तो हॉस्पिटल वालों की शामत आ जाएगी, मुझे इतने लोग मिलने के लिए आएंगे कि जिसकी कोई हद नहीं. And I have seen when you got in, nobody turned out. So this is giving you a false perception. So avoid this. Take regular exercise. Take balanced diet. Balanced diet have an important. Take fruits and vegetables. Avoid junk food, because junk food have the omega-6 in it, and omega-6 is basically pro-inflammatory, which is going to damage your brain. Omega-3 is good for you. That is more in natural foods and fish. So take that. So there are lot of strategies. You don't need to take any exercise. Just follow the nature. Follow your religion. Your religion, basically, every religion that you have, that is focusing on you to follow on the religion. No religion said कि 12 बजे सो के उठें. No religion said कि आप सारी रात जागें. रमज़ान अभी गया है. आप शेयर विथ यू. मोस्ट ऑफ द पेशेंट मेरे पास आते हैं. मैंने कहा सुबह और शाम की गोली खानी. सुबह की जो शाम की गोली कब खानी? मैंने कहा शाम को जब शाम होती है. कहती है हम तो सोते ही सहरी के बाद. This is a new thing that is changing. किसने कहा है? रिलीजन ने तो कभी भी नहीं कहा. नबी पाक ने आप सहाबाए कराम की क्या वो सारी रात जागते थे फिर सोते थे? तो that is basically we are deviating from the nature that have a negative impact on your life.
Sir.
आपके कहने के मुताबिक जो आपने डेफिनेशन बताई
जी
जो पहली स्लाइड थी आपने,
जी
इसके मुताबिक तो ये लगता है कि हम सब मेंटल हेल्थ का शिकार हैं.
ये इंग्लैंड में स्टडी हुई थी और वहाँ पे ये देख नहीं मेंटल मैं वो नहीं कहता मेंटल डिसऑर्डर नहीं है. टू वांट टू बी अ मेंटली हेल्थी आपको अपने पोटेंशियल्स का पता होना चाहिए कि मेरे अंदर ये पोटेंशियल है, मैं ये कर सकता हूँ. आप जिस दिन आपने ये सोच लिया मैं ये नहीं कर सकता, आप यू विल नॉट. सेकेंड थिंग, आप प्रोडक्टिव काम करें. वो प्रोडक्टिव आपके लिए भी होना चाहिए और आपकी सोसाइटी के लिए भी होना चाहिए. अगर मैं सारा काम कर रहा हूँ मेरे लिए है तो वो कहते हैं मेंटली हेल्थ का ये कंपोनेंट है इंपॉर्टेंट. और थर्ड चीज जो डे टू डे स्ट्रेसेस आते हैं और मैं बैठ जाऊँ कि नहीं अब तो कुछ नहीं हो सकता, यू आर नॉट मेंटली. आपको इतनी एबिलिटी और ये जो मैंने लाइफ स्टाइल्स की ये चीजें बताई, यू स्टार्ट डूइंग दैट, यू विल डेवलप दोज थिंग्स इन योर. एंड यू नीड मोर सेमिनार्स लाइक दिस एंड इन विच वी कैन प्रीच, वी कैन ट्रेन you to deal with that. There are a lot of things that we can do, but a lot of exercise that we can do to improve our mental health.
Sir, I have a question. I am Dr. Samira from Department of Public Health. Sir, we have seen that people like going to or they opt for going to medical practitioners, but somehow there is a taboo that they would not like going to psychiatrists. Even if they are going, they would hide it. So how will we then overcome this?
What is the
issue?
reason? I share with you my experience. When I joined Daw Medical College, the first day I entered into my department. तो उस ज़माने में नया नया आया था जो सिंधी नाम लिखे जाते थे हर डिपार्टमेंट के. तो मेरे डिपार्टमेंट का नाम इंग्लिश में साइकेट्री लिखा था, उर्दू में नफ्सियाती वार्ड, और उसके नीचे सिंधी में लिखा हुआ था चेरियन जो वार्ड. अच्छा, जब मैं वहां से गुजरता था, मैं दिस इज अ फैक्ट आई एम शेयरिंग विथ यू, जब मैं वहां से गुजरता था तो मुझे लोग क्या कहते थे? चेरियन जो डॉक्टर. ये पहला स्टेज था. फिर हमारे यहाँ शॉर्ट होता है, हर चीज को पूरा नहीं बोलते, छोटा बोलते. तो थोड़े दिनों बाद उन्होंने चेरियन जो डॉक्टर के बाद ये कहना शुरू कर दिया चरिया डॉक्टर. एंड आई टेल यू वन ऑफ द टीवी प्रोग्राम इन लाइव टीवी प्रोग्राम पर one of the anchor asked me कि डॉक्टर साहब हमने सुना यह है कि जो साइकेट्रिस्ट होते हैं जब ये बहुत अरसे तक प्रैक्टिस करते हैं तो थोड़े दिन बाद ये भी उसके बाद वो चुप कर गया. अब मैं उसको क्या जवाब देता, ये लाइव प्रोग्राम था, मैंने उससे कहा कि अच्छा देखें ऐसा सुने कि एक लड़की है जिसकी शादी नहीं हुई, उसने गायनी वार्ड में बहुत सारी डिलीवरी कराई है और थोड़े दिन बाद वो भी, फिर मैं भी चुप कर गया. So when you understand your mind, तो आप उससे ज्यादा बेहतर होंगे डील करने के लिए या कम होंगे. होता है कुछ लोग हो जाते हैं, बेसिकली मेंटल हेल्थ में बहुत से लोग अपनी डिजीज को अंडरस्टैंड करने के लिए आ जाते हैं, वो फिर डिस्टर्ब हो जाते हैं. यू नीड अ स्ट्रांग माइंड इफ यू आर ज्वाइनिंग दिस फ्रेटर्निटी. एंड अब जो है अवेयरनेस जो है उसमें जो 98% इलनेसेस होती हैं, दे आर नोन एज माइनर इलनेसेस, डिप्रेशन, एंजाइटी कॉमन है और ये सब बहुत सारे लोगों को होती हैं. 2% इलनेसेस जो होती है जो मेजर डिसऑर्डर कहलाते हैं, जिसमें साइकोसिस होता है. ये वो डिसऑर्डर होते हैं जो आपको दूर से नजर आ जाते हैं, रोड पे खड़ा हुआ है और ट्रैफिक रोक रहा है. ये जो साइकोटिक पेशेंट हैं जिनको आम जबान में पागल कहते हैं, ये बेसिकली वो लोग होते हैं जो कि एक पूरा वो बन जाता है. तो 98% लोग उसकी वजह से, उस टैबो की वजह से नहीं आते हैं. सो दैट वी नीड टू लर्न. अब काफी अवेयरनेस हो रही है एंड थ्रू दैट अवेयरनेस वी कैन एटलीस्ट, आप जब कोई मेंटल प्रॉब्लम हो आपको, और मोस्ट ऑफ द टाइम क्या होता है कि वो फिजिकल प्रॉब्लम्स के साथ प्रेजेंट करते हैं, तो आपके पास बहुत सारे, आप जाएंगे तो बहुत सारे डिफरेंट डिपार्टमेंट के आपको मेंटल इलनेस के पेशेंट्स होंगे, बट दे आर गोइंग टू प्रेजेंट विद सोमेटिक कंप्लेंट्स और इस तरह से प्रेजेंट करते हैं. ठीक है. एग्जैक्टली. स्टूडेंट्स, क्योंकि ये बड़ा इशू हुआ था डॉ में, एक स्टूडेंट जो है उसने ये किया कि ही वाज डिस्टर्ब, उसकी पोस्ट कुछ इस तरह, मैंने बाद में उसको जब ऑटोप्सी की तो पता चला, तो उसने क्या किया कि एनेस्थीसिया वार्ड में था, उसने एक ड्रिप के अंदर एनेस्थेटिक ड्रग डाली और वो डाल के और वो सो गया एंड ही डाइड इन द मॉर्निंग. तो वो बहुत एक प्रेशर आया. तो फिर उसके बाद ये रियलाइज हुआ कि स्टूडेंट्स हैव लॉट ऑफ स्ट्रेस एंड देयर इज अ नीड टू हैव अ काउंसलर in every institution who can help those students, not only them, but the healthy student, they can advise him that how can we enhance our potentials, because identify your potential is one of the important component of your mental health. ठीक है जी.
Thank you very much for a very good presentation, and I'm glad that a national survey you have conducted, which is very much needed. I'll talk about, or maybe going back to a couple of papers or research I have done myself in Karachi, one with Dr. Murad Musa, professor of psychiatry at Aga Khan, and another one with taking sample from Karachi and drawing the sample with the help of Pakistan Bureau of Statistics. One study was related to depression among the elderly population of Karachi, 60 plus. And we found about 45% of them were, they had mental issues, mental health issues. And in the general population of Karachi, it was, we just did it about 3 years ago, it was about 30%. In both cases, women were reported higher depression rate of mental health than men, as you also reported here. What's the reason that you have much lower rate of mental health illness in your survey?
When this article was published in British Journal of Psychiatry, they have a lot of critique about those 20 studies. There was a flaws in methodology, that tool they are going to use. That tool which we are going to use, most of the time we are going to use that screening tool. Because depression, everyone got depressed. Everyone got, but this is not depressive disorder. For to diagnose a depressive disorder, you have to have a proper tool, proper interview. Then we would, I don't know that which tool they are going to use. If they are going to use those proper interviews, then you are going to get the same thing. This is the issue that we are facing a lot of, critique from the people, that is over here, why it is over low. This is just what I believe, that what we have followed, what have been followed internationally. And this is one of the important tools that everyone, any one of you want to, see it, I have with me, and we have translated that, and we have to do it.
It's a very comprehensive questionnaire.
That's one of the reasons, that because of that is.
Thank you very much. One more question, please.
Just a very simple question. What is agrophobia?
You were listing different types of mental
Yes.
problems.
Agrophobia.
Agrophobia.
Social phobia is basically something you are fearful of that. If that fearfulness consists all of the time, 24 hours, you decide that this is anxiety disorder. But if this is related to something that it is phobia. If you are fearful of coming to the stage, this is social phobia. And if you are fearful of going to the heights, then it is agoraphobia. If the people are fearful of, going to the height, and some people are fearful of going into the crowd, there is claustrophobia. So there are different names that are being given simple to phobia.
Doctor, just final question. I don't want to take too much of your time or you showed us a slide about income and mental health issues. What is the is it higher among the higher income group or lower?
Almost the prevalence is similar, but this is more in lower income group because the life stressors and all those things are more in those groups, but even higher groups are not spared of that. And particularly psychotic illness, they are equal in both in lower income, higher income, psychotic illness. But minor affective disorder, anxiety, depression, they are more in lower income group as compared to higher income group. Thank you very much.
Thank you, sir, for sharing a thoughtful insight on the current mental health situation of Pakistan and sharing prevalence of mental health diseases. Next, we have Honorable Speaker, Professor Dr. Inayat Hasan Thawar, medical graduate from Dar Medical College. He holds fellowship in community medicine, master's degree in maternal and child health. He has done PhD in health policy and planning from UK. His earlier career earned him to be a pediatrician by having DCH and MCPS. He has a combination of expertise in learning, teaching, and practical application of public health. He has worked in AKU, Bakari, Fatma Memorial College, Al-Shifa School of Public Health, and Health Services Academy. He had also contributed to UN agencies, British High Commission, and established Mustasir consulting firm. He's been one of the pioneers and founding members of NGOs like PWA and HANDS. Currently, Dr. Inayat is the professor and head of Department of Community Health Services at Bahria University Medical and Dental College. He has more than 35 years of experience in practicing and teaching public health, and teaching experience varies from undergraduate to PhD levels. With extensive experience in developing policy and strategies and conducting health system research, working with government, non-government, and international organizations. He has more than 100 publications to his credit. I would like to invite Professor Dr. Inayat Thawar and grace us with your treasure of knowledge and experience on social and mental health.
Bismillahirrahmanirrahim. Thank you very much. I would like to really thank you, Professor Dr. Raza and Professor Fareed Nad, because they have made my work relatively easier by, like sharing a number of the things. Okay. Now, what I am going to share is the social and mental health issues, and this is related to the COVID, because the COVID has been there. Still, I am fearful of the COVID, so there must be a name for that also, So everybody has a share in COVID, and you can see the list, and I'm not going to read out, and there you can actually add to that further list. So everybody had made contributions or claimed for the contribution. And there were losers and gainers. Of course, the pharmaceutical agencies and whatnot, but I will actually talk about the losers, and these were the job losses, closure of the businesses, countries had economic problems, closure of the country borders, travel became more difficult, and we can actually talk about the politicians. There were losers and the gainers. So moving on, what I'm going to share, and this is my privilege, and I discussed this with Dr. Karim, and he said that yes, why not, is actually to share you with what our students of the 4th year have done various research as part of their curriculum activities during the last 3 years, and this is for the first time that I am sharing you this all. Many of these are actually going to be published soon. And I've actually divided it, and I'll then conclude it. First is, and of course this is not encroaching into your field, but as you defined into the social, mental and physical well-being, and these are not highly sophisticated research, but done by like anxiety and depression in the childbearing age women and the general population. Okay, mental health variables, anxiety, what we found, and this is during the COVID. So bear me, and this was the HAD scale, this is the commonly used by the public health people. So, and this has got a good validity, almost 60%, and there were actually problems. This is regarding women, reproductive age women, and there were sleep disturbances, and I'm sorry this could not be seen, but the 18% were that the women had actually admitted that they had suicidal tendencies, which is very alarming. Perceived causes of the mental health, and this was very interesting when they were, why you think you are disturbed, why you are having different problems, except the poverty, which might have been not there, because these were the women who were actually responding to the online questionnaire. So they were educated, but they had the problem because of the disease, which is COVID, the husband's job, the children who were not going to the schools and maybe teasing the mother, and home environment which was very tensed up because everybody was living together for 24 hours because of the lockdown and various issues. ये क्या हुआ? Why it's not moving? Okay. क्या हो गया भाई? No. भाई आपका यहाँ मशीन में प्रॉब्लम है. Right जी. Okay. This is regarding the general population. Moving on, and I'll just give you the selective flavors of the different research. No anxiety, 60%, but then 40% had some level of anxiety. Depression, okay, 40% did not have, which means 60% had some level of depression. ये भाई आपका क्या मसला है? Okay. Coping mechanisms, what they have done, and this is very interesting. What Professor Raza actually mentioned was that when they were sitting with the friends, they had more anxiety as compared to the issues when they were actually praying to the God or playing games or spending time with the immediate family. So they had their own coping mechanisms with them. Right, then there are actually groups of the studies which are related to the students, and perhaps you might have actually, the students sitting over here have done, which is that suddenly we went into the virtual learning, the sleep patterns, the stress and eating habits among the house officers, which are the doctors, social and family issues, and impact on the lifestyle and dietary factors and the family planning. I'll take one by one very quickly. Okay, sorry. Learning, virtual learning. because it was sudden and because it was, so the teachers were learning how to go online and also the students were. So most of the students did not like, and this was the early, 20s period where they were actually, we were trying to find out. And except, more than half, they said that, okay, online actually helps for the group discussions and it saves the time because, and I'll tell you some anecdotal evidences also, more of the stories. Right, and overall satisfaction, there were actually problem on the, there were no statistical differences as regard the sex and different groups, but only the urban-rural. The urban were more satisfied as compared to the rural ones, and probably the difference was actually related to the internet connection. So at that time the internet connection was about 56%, and luckily the speed was fairly good. And as you would know, I don't know what you were using, we were using the Microsoft Teams, some people use Zoom in the initial period, and everybody was then using it, the Zoom, and then moving on to the Google Classroom also. Right, moving on to the another one which is also related to the students is the sleeping patterns. And I think what Professor Raza said is actually supporting this fact that actually only 30% of the people who are there, who were still sleeping late, but rest of the students were sleeping after 12 midnight. So that's usual. And this was probably mainly in Karachi, but Professor Raza, you would bear me out, I spent 20 years in Islamabad. I would see that pattern changing, in Islamabad, relatively people go to sleep earlier. Madam Shkanaz has lived over there, but of course it might vary. Right, Ji. Now the interesting part is that they did have a good sleep, which means, again supporting your point, which is they have been sleeping for quite a number of good hours, about 5 to 7 hours, which is fairly good. So which means that even if they are sleeping very late in the 3 in the morning, they were sleeping late in the morning, so that was यार ये क्या हो रहा है तुम्हारा? Okay, so we use the Pittsburgh Sleeping Quality Index, and this is one of the indicator of sleeping efficiency, which means they had a fairly good sound sleep. So almost more than 75, more than two-thirds, I would say, had a fairly good sleep efficiency. And the score of the quality of the sleep, which is supposed to be below 9, two-thirds also had a fairly good quality of the sleep, which means though they were sleeping late, but they had a fairly good quality of sleep. Moving on to another study, which is the house officers, and you would see that there were actually stress factors more in the females as compared to the males, and they were actually the existing the eating habits actually did change. So and it moved towards एक मिनट, ये कहाँ यार तुम लोग, ये तुम चला रहे हो या मैं चला रहा हूँ? हाँ नहीं ये क्या हो रहा है? I think something is wrong. जी
ये बैक साइड
हाँ
ये राइट साइड
नहीं ये आगे जा रहा है ना हाँ चले ये आगे जा रहा है okay this is family and social issues related in the family and it was seen that during the COVID like there were quite a number of the family issues, family fights and minor dislikings and all those things, and even the social issues were actually there. The number of the families, and I'll talk more about when I change it. Association will यार ये तो आप लोगों ने कुछ गड़बड़ की ये देखा ना ये देखें अब पीछे जा रहा है आगे जा रहा है नंबर ऑफ द फैमिली मेंबर्स ना हाँ मेरा ख्याल है कि जी मेरा ख्याल है यही हो रहा है आप इसको पीछे लें हाँ जी now this actually shows that the number when the family had a good number of the family members then they had relatively lesser problems as compared to when they had the smaller number of the family members. Next. Right, Ji, different aspects of lifestyle during COVID among the adolescents. There has been a change in the eating habits and the pandemic had impacted their physical activities and there has been an increase in the daily screening time. So, there were actually issues with the adolescents during the COVID time. Next. And what it was noted was that interestingly those who were doing exercise, they kept on doing it even during the COVID. So it did not change, which is a good sign, which means that it must have been a habit with them. Next. Right, Ji. And these are the good signs, there were takeaways and but there were people started practicing at home and cooking and getting themselves involved and it did not change. I mean this was probably sort of an interesting because it was felt that people would go more for the takeaways or online ordering. Next. Right, Ji, sleeping habits during the pandemic, there was change in the sleeping routine because most of the adolescents going to the colleges or universities, they were not going, so they were sleeping in the daytime and the time of sleep also actually changed, but the quality of sleep was really good. So I think the students enjoyed the COVID time. Next. Okay. Increased amount of mindless scrolling. Just imagine how much it has increased and similarly for the increased screen time. This was but natural, one can argue, but this was there. Next. Right, Ji, moving on to the family planning. What happened to the family planning? There was a fear that the contraceptive health services and MCH services will be affected and there was a big dawn, editorial of news saying that so many people, females will get pregnant. Interestingly, it did not change a lot, which means I think the contraceptive prevalence, of course it's a small study, but it shows that people though actually moved on to the online ordering and and they were actually coping with that mechanism. Next. Right. Availability of the family planning service, yes, it had problems and there were access problems also, but like any program or ad, we wanted to find out whether the government is proactively looking into it. No, I've got 30 minutes. Don't see that. And delay in the shipment of online. Yes, there were problems. Next. Avoiding family planning. This was a tough time. And look at that. Imagine a couple both working online and then taking care of the children and taking care of the schooling of the children. The workload at home actually resulted in a lot of exhaustion, decreased opportunities for privacy, and also the anxiety affected the couple, private life. So there was some natural family planning which also happened during the COVID time. Next. And interestingly again, this was amazing that the same pattern was there as regards the contraceptive uses, which means the condoms and the pills and then IUDs and all those things. Next. And decreased opportunities and accessibilities were actually significantly affecting the family planning practices or supporting or whatever. Next. Right, Ji. How Pakistanis are reacting. This is the last year rather and beginning of this year. Now the people have got fairly good knowledge. They know what is COVID, what happens and everything, but the perception, especially the negative perceptions, are still there, were still there. I would say the last year, of course, this year will be another work being done. And then there has been a negative attitude also about the COVID. Next. And the negative attitudes were that some of them were vaccinated and they were willing, but then they were actually really it is not safe, and then related to the fertility and whatnot, and these were the issues that they had actually pointed out. Next. And the point is that the perceptions actually were influenced mainly by the income level, which means the lower the income and probably the lower the education, which had actually inculcated those all negative. We had a female cook and she consistently refused to vaccinate herself until we have to really tell her that you stay at home, and she would still not really get it done. Next. We are doing one study on the fearfulness of COVID now and then, and soon we will be getting the results. But just to conclude about what number of the studies that I have shown. Next. Right, Ji. So end of 2019 and 20, there was a stage of denial, disbelief, and we all thought that it's going to be limited. And then of course moving on to the second stage of when it started having impact, and the first impact was on the mental health. So I show you the mental health issues among the women, among the general population, and then this followed on to the loss of employment, loss of businesses, and so on, and then the other issues, the family planning issues. And now people are actually talking about the new variants, and people like me has got still some phobias. So this, I would say, is an amazing time for the epidemiologists, for the public health people to really understand. And interestingly, in Pakistan only, 500 research have been published just on the COVID. You know, just imagine, and then of course I don't want to really put the, I don't know even the number, you know, like anybody, anything would write will get it published. So it was, you know, like it was a luxury for the researcher. In fact, in the initial time I wrote an editorial on COVID-19, a daredevil or a blessing in disguise. And of course, I started arguing on what are the blessings that we are getting by uniting the families and sitting together and working together. So, right, thank you very much. जी जनाब नो क्वेश्चंस जनाब
Do we have any question from Dr. Inayat, please? Only 2 questions.
If you don't have a question, I can have a comment which is very
Yes,
interesting.
please. Yes, please,
And my personal experience is that हम जब क्लास लेते थे तो सुबह 8:30 बजे क्लास शुरू हो जाती थी और वो शुरू में ये था कि कोई वो ऑनलाइन अटेंडेंस मैकेनिज्म नहीं था. सो वो जो है वो बस ऐसे ही होता था, CR से कहते थे अटेंडेंस लगा दो अटेंडेंस, फिर ऑनलाइन भेजे. फिर नाउ द IT डिपार्टमेंट इन्वेंटेड समथिंग वेयर बाय यू हैव टू लॉग इन. तो वो स्टूडेंट्स ने ये चालाकी की कि वो खुद तो उठते नहीं थे सुबह 8:30 बजे, वो ये करते थे कि अपने अम्मी अब्बा भाई छोटे किसी को कहते थे तुम लॉग इन हो जाओ तो अटेंडेंस लग जाएगी. अच्छा, और मजे की बात ये थी कि वो चूंकि रिकॉर्ड होता था वो सारे बच्चे रात को उठकर, जब वो जागते थे रात में, तो रात को उठकर फिर वो लेक्चर सुनते थे. सो वाई वी नोटिस दैट कि हम फिर वो सवाल पूछते थे स्टूडेंट से तो जवाब नदारत, किसी का जवाब ही नहीं आता था. तो लाइक 3 मरतबा 4 मरतबा, देन वी शेयर्ड इट विद अदर कोलीग्स. सो वी फाउंड दैट अल्टीमेटली कि यार ये कुछ गड़बड़ है. एंड देन वी चेक्ड इट विद द स्टूडेंट्स ऑफ कोर्स, देन दे टोल्ड अस कहाँ सर ऐसा तो होता था. सो लाइक जी.
I thought that you have a sample student audience sitting here.
Yeah.
You might want to ask them 1 or 2 questions just by a show of hands. If you would like to ask them.
Yeah, I mean, I don't know. I mean, like, is that I would actually like to maybe do a triangulation by asking, do you think that this is what has happened with you or not?
No, ask
yes, ask for the yes.
Ask them a specific question.
Okay, specific question ये है कि जिन घरों में जो है द ओल्डर पीपल रहते हैं, क्या उन घरों में when you were sitting at the during the COVID time, during the lockdown, did you feel a difference or not? No answer.
Their social interaction.
Yeah, their social, yeah. So, I mean, जी.
Yes, sir, definitely. We out of their health consciousness, social interaction बहुत कम हुआ था, and we distracted from the social gatherings and social interactions from our parents कि कहीं हम अपनी बीमारी उनको ना लगा दें. तो in that terms, yes, there was a decline in the social interaction.
अच्छा, interesting.
We need to go to the next speaker. For our interest, at least I would like to ask my students a question, and you can raise your hands for that, okay? How many of you felt you were spending more time on your cell phones and on your PCs? How many of you felt during COVID, that first lockdown of COVID, how many of you spent much more time on your cell phones and your PCs?
Everyone.
Almost everyone, okay? That's a very simple, no-brainer question. All right, now let me ask you, how many of you changed your sleeping habits significantly? How many of you were sleeping more during COVID?
Wow. sure. Definitely. For
You
sure,
were sleeping more during COVID.
देखिए मैडम जब बच्चे घर बैठते हैं वो कहते हैं कि सोना है.
How many of you were sleeping after 12 o'clock at night, generally? Okay. After 1 o'clock? After 2 o'clock? Yeah, okay. How many of you stayed awake most of the night till 3 o'clock?
देखें.
Look at that.
इसका मतलब है मैडम हमने झूठ नहीं कहा.
No, I'm just trying to, this is reinforcing what you were saying.
Exactly.
And obviously you spent much more time with your family.
Yeah.
How many of you maintained the same physical exercise during COVID that you did during normal times? Same physical exercise routine? Much fewer. That's good to see.
Thank you, madam. Thank you. Thank you all.
So,
we are running short on time. Just one pointer, because I have taught you sociology and social and behavioral aspects. So, which I observed in my children were major personality issues, and they were irritable, agitated. Although the family time with parents were increased, screen time was increased. So yes, strategies were developed. We pushed them towards more physical activities at home. But yes, not just the geriatrics, but I still find major personality issues. Thank you. So thank you, sir, for your enlightenment. Okay, thank you, sir, for enlightening us with the mental health issues and highlighting the challenges in Pakistan. Last invited speaker for this plenary session, we have Dr. Assanil Khan, a public health professional and reform enthusiast with a career of more than 20 years in research and practice in public health, healthcare policy, and strategic development. He has experience in developing systems strengthening through reforms in institutions, regulations, financing, and been part of health insurance programs, healthcare services, standards and quality, public-private partnership development, smart monitoring systems, blockchain, smart contracts, and multi-sectoral partnership development and contracting. Dr. Assanil Khan has performed as a leadership roles in the public and private health sectors in projects with WHO, USAID, and DFID at country and regional levels that includes experience of working in developing countries and conflict regions. I would like to invite Dr. Assanil on the podium and highlight poverty and public health issues in Pakistan.
राइट लेफ्ट यहाँ से होगा, इसको आप बीच में प्रेस करेंगे, सही होगा.
Bismillahirrahmanirrahim. Madam Shahnaz, for the panelists, I think it makes it more difficult for people like us to add to the richness that has already been provided. I think such an aggregate of experience Madam Shahnaz would not remember, or maybe. I served in with Sindh government as Chief Health Sector Reform Unit, and there too we learned a lot when she was leading and coordinating the primary health care and family planning there. And I think that was a parallel leadership that was very much required, and looking at her actually is, it gives us a professional like us a real big motivation. Can you hear me? Speaker say that. Because this needs more than academic excellence, and that drive that we all have. It requires that missionary approach that I have seen, I mean, in the leadership like Madam Shahnaz. I would also like to congratulate SZABIST team, all the contributors, Professor Mehtab, Dr. Samira and the team. It is very opportune time actually to have this kind of an event, because a lot of funding is converging, and many of our colleagues would know
World Bank is coming with a very hefty funding. There is a USAID funding that is in the pipeline, all converging on the health, and of course this perspective is very important. Although the scope of this nexus of poverty and health is such a big scope that one can add only perspective to it in these 2 days event. Like my worthy panelists, they all added an angle to it from Professor Fareed's view of maternal and neonatal infant mortality and its nexus with the income quantiles and poverty, and of course more focus on the mental health, which is also very important. One thing that I realized, and I was reading it, that with all the public health problems, all of them are converging towards something in the system. And that's what we actually, and as has been embellished in the introduction, I've been doing for last 10-15 years, to focus more, and especially in this part of the world, focus more on the systems approach. Something is wrong there. Something is blocking all these efforts. And because not much time is left, we have already taken much longer in our previous presentation. So I'll just focus and I'll give you a perspective on this today's topic, the nexus of poverty and public health. I know much of the data that you have seen in these presentations, in these 3 or 4 presentations, have broadly given you an impression that more of this problem or poverty and related issues are towards the rural side. Urban side it is taken that they have most of the things, they have no access issue, most of the challenges are skewed in the broader data interpretation towards the rural side. But let me give you this picture. And it's a myth that has not been declared by the data that I'll be showing here, but most of the organizations. Ji, please, next, sorry. All right. So this is a picture where you can compare different countries, same income bracket, and you see, and especially just 2 indicators that we can compare. You see that Kenya, Ghana are very much near Pakistan in terms of the per capita income. It may have changed in last 2 years or 3 years, but it is very much close. But if you see the out-of-pocket expenditure, this is the expenditure that is done at the point of service. जब आप जाते हैं सर्विस लेने के लिए, वहाँ पर अपनी जेब से जो आप दे रहे होते हैं या वहीं पर जो पे कर रहे हो, that's the out-of-pocket expenditure. And if you compare it, see Kenya and Ghana is the out-of-pocket expenditure is almost half than Pakistan, and it has actually worsened. So some would say it has reached 70%, not standing here. So I'll just quickly go through different angles to give you one more thing which is changing very quickly. The sheer denominator of the population, and I know this touches the political realm also, but this is a reality, and this is what is coming. Actually, we have gone through this barrier. So the sheer denominator is the people and family and household due to migration, due to the shifting and many other reasons, a very quick urbanization is happening. Even in Pakistan, I would argue that it will not take 2025. It has already reached in many regions in Pakistan. And maybe for Sindh, we can say that it has exceeded as far as the definition of the urban structure is concerned. And it has been concluded that the public health issues are much worse in these populations. And this is also a generalization, the urban population. Within the urban population, for example, in Karachi, we will see it. 60% of it resides in the urban slums and the low-income communities. There, because we don't have that precise data as yet, or maybe some organization like UNICEF had conducted some profile, some part of the profile in the urban area, but this is important. In urban slum, the maternal mortality, neonatal mortality, infant mortality is much different than the generalization of the urban indicators that we share. In Sindh, again, sheer number, the census, we may question plus minus of it, but this is important, that the urban population has exceeded the rural population. So the sheer number is actually directing us or indicating a system change in terms of our approaches. In Karachi, and this is also according to the available data or the census, you can see that the urban, there is a rural part to it also, but there is the majority is the urban population. And within the urban population, in this slide it is important to appreciate that these red spots or the areas, these are the major slums, and these are interspersed between the so-called high-end areas. So these are in all the districts within the Karachi. There is another angle to it. Now, and this is another myth. We define, or it's been taken by, people like us who actually are learning every day, that perhaps poverty line is a static line, because the numbers actually sometime holds you to go deeper than the numbers. Instead of taking an indication from the number and go qualitative, we stay there. And here you can see in this pyramid that the above poverty line, there is another line. And between these two, there is a dynamic population that is every day, every week, every month dipping into or dipping down the poverty line. Some are coming up, but most of them are going down, especially in the contracted economies and the macroeconomic situation that we have. So with this, we understand that any program, any approach covering something static, below static poverty line will not be sufficient. It is a very dynamic population flow across these lines. Here's another nexus between the poverty and the health shocks. So if we calculate, and this is the data that's been there, all professionals know it. So more than 50% of the shocks that take you into the poverty are because of health. Clearly a big piece that you can see. And for that, to give some coverage, some support, Pakistan government had been moving on this health coverage program. And by the way, it has been a saga, it has continued. Many have contributed into this. It's not one instance of one single year that many of us would perceive that this started some in 2009, but a lot of work has been contributed. And one of the precursor of this coverage program was Benazir Income Support Program. Wasila Sehat was a program design on which KFW and other international agencies, GIZ, built upon and gave you this national health coverage program. Many would not call it an insurance program, but this national health coverage program is actually has started from there. And as I've shown it, this is the saga that should continue further. Why? And this is from the third-party validation that has recently been conducted in Punjab and other provinces, that unless we have a bigger pool, unless we include, as I've shown in the pyramid, that there are other income quintiles, there are other above the poverty line that are continuously moving across the lines. Unless we include those, and unless we have this combination of contributors and subsidized pool, any coverage program at national level will not be sustainable. And it has been proved from different national programs that are there in the region and world over. Pakistan still is financially, as far as the financial protection is concerned, covers not more than 4.4% in the region. With the low growth economy, I think more of the population has dipped or gone down the poverty line. So these are the rationales on which it has been suggested that the programs, the national programs that are there are not sufficient, and I think there is an increase, there is a need for an addition to such programs. Based on this rationale, we started an analysis of the policy for national health coverage, and it has been supported by Health and Nutrition Development Society hands here, because the study setting is in Karachi. Some glimpses from it. We have excluded those who are defined as within the poverty definition under the with income under $2, and they have been excluded, and it has been conducted within Karachi. As I've been indicated that the time is limited, so just this is one part of the research or the study. There is a qualitative and quantitative part. It's a mixed study. The quantitative part actually, and there are only preliminary, very initial results that are coming, and I'm sharing it with you. This household survey was conducted in 6 districts. Kiamadi was not added at that time. So in 6 districts it was conducted. We also made use of the community health workers, the LHW that are there, and that I realized that community health workers, not only the service provision, but as a knowledge management structure, these are very effective. This structure is very effective. Very initial results that are coming in, we see that this is the household total expense, one of the proxy indicator for income. So in the areas that we selected and went to, most of it are spending about 20,000. Within the 20,000, those who are spending between 15 and 20,000 are much higher. One of the aspects, and there are many things that are coming from the survey. One of the aspect is how much they are spending or the expenses they have in that month of survey on the medical expenses. So this was the reflection from Karachi, and these are the urban areas. Many of them have actually, you can see that the central data between 2,000 and 8,000 is majority of them. There is a medical expense that is more related, and this is the detailed granular data that is coming more related to the maternity. That's why about 10,000 rupees is booked there, and you can see that there is a higher proportion there. In terms of hospitalization in last 12 months, how much they have spent or what is the expense on the hospitalization, and the bar that you see on the floor of it actually is reflective of those normal maternity cases and maternal the childbirth related healthcare expenses. This is very important that when asked where did you expense out this medical expense, so many of them had used their current income, but you can see that many of them has borrowed from family or friends. In terms of, this is the potential of where this urban population can come together and pool in. So this is, these are two aspects of the social capital that we have in this study setting, and we can see that a lot of people are participating in community group activities, and there is a potential community cohesion that is available. It's another potential for, if we look at the social capital of the community, this is another potential. So many of those respondents agree that there should be a pooling mechanism. But that's the glimpse of what we have actually learned, and these results are coming in, and they are showing promising results that in the contribution model for any health coverage program, urban side is very much ready. I will not generalize it, but within Karachi, it is very much ready. So I think I will end there, and this is one aspect that I wanted to add. Thank you.
Thank you, sir, for sharing the information and providing insight on urban myths in vulnerable urban population. Now, I would like to request Madam President on stage and present shields to our honorable speakers. Madam President. Please, Dr. Kashif and Sir Mehtab Karim. Professor Dr. Fareed Nad. Sir, please. Sorry. Picture ले ले. Thank you. Professor Dr. Awazariman. Please, sir. Welcome. you, sir. Professor Dr. Inayat Thawer. Sir, please. Thank you, sir. Dr. Assanil Khan Wazir. Thank you, sir. And in the end, Professor Dr. Karim, Madam, please present. Sir. Thank you. Ladies and gentlemen, now it's time for a tea break. I request our reputable guests and faculty to proceed towards the meeting room for refreshments.
Back in 10 minutes.
Students, you are requested to remain seated. The virtual session will commence right away due to the late schedule. Thank you. मैम को खड़ा नहीं, मैम ने मुझे कहा था कि बोलना नहीं, तस्वीर खिंचवा देते हैं ना, मैंने उनको रोक लिया। Students, please remain seated. You are not allowed to leave the auditorium. Kindly, please remain seated. Maintain the decorum.
लिंक कनेक्ट हो तो मुझे बता दीजिएगा, फिर मैं बोलना स्टार्ट करूँगी। क्या हुआ? वो मैं इसीलिए लिखना चाह रही थी कि आपको बुलाऊंगी ऑन स्टेज, मैडम समीरा प्लीज ना। एक चला दूँ एक, फिर गलत लाइट ऑन की है, ये वाली की थी ना मैंने, पोडियम पे जो आती है लाइट, बस।
Students, please settle down. Please, thank you.
बेचारे मजलूम हमने उनको बैठाई कौम, पता है कौन सी मजलूम कौम बैठी है, बच्चे बेचारे।
Ladies and gentlemen,
ये सुनो, पैरानॉर्मल एक्टिविटीज़ ना करना, ठीक है?
okay, ladies and gentlemen, we will proceed further with our virtual sessions. The emergence of virtual world with pandemic has enhanced mediums of collaboration and building alliances globally. This conference reflects the dynamics and role of public health, which has been modified. It is yet again an opportunity to invite prestigious international speakers from Indonesia, Iran, and Bangladesh and seek inspiration from their work. We will begin now with Dr. Mushtaq Chaudhry from Bangladesh. Dr. Mushtaq holds a PhD from London School of Hygiene and Tropical Medicine, MSc from London School of Economics, and BA in Statistics from University of Dhaka. He has published nearly 200 articles in national and international journals. Dr. Mushtaq is a former vice chair of BRAC, the largest non-governmental organization globally. Previously, he was its executive director, founding director of research and evaluation division, and founding dean of the BRAC University James P. Gans School of Public Health. He is also professor of population and family health at Columbia University, New York, which made him first Bangladeshi to hold a professional position in an Ivy League university. He has worked as a senior advisor and acting managing director at the Rockefeller Foundation and as a MacArthur Fellow at Harvard University. He is an expert of universal health coverage in low and middle-income countries, on which he has written extensively. Dr. Chaudhry received many awards, including the prestigious Medical Award of Excellence given by Chicago-based Ronald McDonald House Charities, and has been honored by the Lancet for his contribution to global health. Dr. Chaudhry is the founder of Bangladesh Education Watch and Bangladesh Health Watch. He is on board and committees of several organizations and initiatives. I will be taking on board Professor Dr. Mushtaq. Please enlighten us with your experience.
You want me to repeat again? Assalamualaikum, sir. A very warm welcome to our conference. I hope I'm audible. So would you like to say just a welcome note so we can make sure that you are audible to us? He's not audible.
Me?
Sir, am I audible?
Yes, I can hear you. Can you hear me?
Yes, sir. I think you are audible, but it's still not very loud and clear.
I see. So I'll be closer to the microphone.
All right,
and
sir.
and see whether it works better.
Thank you, sir. Thank you. So, sir, we will proceed further with our virtual sessions, and the emergence of virtual world with pandemic has enhanced the mediums of collaboration and building alliances globally. So, this conference reflects how the dynamics and role of public health has been modified. It's an opportunity to invite you as a prestigious speaker. Dr. Mushtaq holds a PhD from London Schools of Hygiene and Tropical Medicine, an MSc from London School of Economics, and BA in Statistics from University of Dhaka. Published nearly 200 articles in national and international journals. Is a former vice chair of BRAC, the largest non-government organization globally. Previously, he was an executive director, founding director of Research and Evaluation Division, founding dean of BRAC University. Also professor of population and family health at Columbia University, and made his first Bangladeshi, he was basically a first Bangladeshi to hold a professional position in Ivy League University. Received many awards, including the prestigious Medical Award of Excellence given by Chicago-based Ronald McDonald House Charities, and was honored by the Lancet as contributions to global health. He is the founder of Bangladesh Education Watch and Bangladesh Health Watch. He is on board in committees of several organizations and initiatives. So, welcome, sir, on board, and please enlighten us with your experience.
Thank you very much. Thanks for your very generous introduction. I'm so pleased to be connected to this very important international conference. A very good morning and assalamu alaikum. I think it is still morning in Pakistan, so very good morning. I'm so pleased to be here at the Shaheed Zulfikar Ali Bhutto Institute of Science and Technology for this international conference. So at the outset, I wanted to thank the SZABIST for inviting me, and particularly my friend Professor Karim, who himself is an icon and is one of the top demographers of South Asia, and we know each other for quite some time, and I'm very proud to be know him. Ladies and gentlemen, last year, 2021, was the 50th anniversary of the birth of Bangladesh. And there has been a lot of interest and discussion about Bangladesh lately in the global literature, also in the media and so on. But over the last 50 years, Bangladesh has had a very checkered history of progress. And when Bangladesh was born, we had the level of a kind of a basket case. Which was uttered no less a person than Henry Kissinger. But over the last 50 years, the things have changed. It is now labeled as a basket of innovations. Although Bangladesh has done well, but obviously there are a lot to be done, and there is no room for complacency. So in these few words, I wanted to share with you the Bangladesh story here. Through this presentation, I'll be short and try to be precise. And I'm so grateful to all of you for this opportunity. May I have the next slide, please? So as I said, that we have been having a lot of attention, the country over the last, during the last few years. Bangladesh seems to have come from the backyard to the courtyard of South Asia. Only last year we have birthed into a developing country status, and formally we will be moving into that in 2026. There has been a lot of discussion about some of the successes that Bangladesh has made over the years. and the Lancet, which is all of you know about the Lancet, they did a Hello.
Hello. Yes, sir, you're back. Just there was a disconnection for 2 minutes. Please
Am I audible
continue.
now?
Please continue, sir. Please continue. You're connected
Okay.
again. Thank you.
Okay. Okay. So Bangladesh is also at the forefront of climate change, as you know. But also in that front, we obviously, as you know, we can do much in mitigation of the climate change thing. But we have been trying different ways to adapt to the changes caused by climate change. And Bangladesh is known also as the home to many of the successful NGOs. But as I said, that there is hardly any room for complacency because we have in front of us the SDG 2030, the Agenda 2030, and also what we call the Vision 2041, when Bangladesh hopes to move into a developed country status. Next, please. Next, please. Next, please. Am I audible? Oh, yes. Next, please. I'm sorry for the technical glitch, but hello.
Am I audible? Yes, sir, please continue. Can you see the slides getting changed on your side?
Can you hear me now?
Yes, sir, you're audible.
Can you go back 2 slides, please? Go back.
All right, sir.
Can we go back?
Okay. Gender gap index. Disconnected.
Hello?
Yes, sir, you're back again. Sir, please continue. Can you see your screen?
Can we go back a little?
All right.
2 or 3 slides.
Please go back 3 slides.
One more or 2 more. Go back, please. Sorry.
All right. It's okay, sir. GDP per capita. Again disconnected.
Go back further.
This one?
Hello.
Okay, sir. We are at the beginning of your presentation. So, disconnected or whatever. Connect.
Can you go back a little bit more?
Yes, sir. It's from the beginning of your presentation.
Yes. Thank you very much. Thank you very much.
Yes.
I'm sorry for this distraction.
It's okay, sir. I'll be controlling your slides. You can just mention where to stop.
I'm sorry for the technical glitch. Next, please. Hello?
Yes, sir, please.
Can you go forward, buddy?
All right.
Can you go forward? 2-3 slides, the one on poverty.
Okay. We have health system indicators and health outputs, total fertility rate, population growth rate.
Go ahead. Yes, this is the one. So this slide shows the GDP per capita in Bangladesh and in comparison to some of our neighbors. And as you can see that in 1972, when Bangladesh became independent, Bangladesh was the poorest country in South Asia in terms of the GDP per capita. Oh, go back, please.
Okay, sir, I think there's been a delay. You're receiving slides a bit late, so I will just go back to the GDP slide. Okay, sir.
Okay, in the previous slide, what I was going to show is that although we started very poor, but over the years we have made good progress. Now, apart from Sri Lanka, Bangladesh has the highest. Is going too fast. Please go back.
Sir, we can give you the control of your presentation if you would.
Shall I try it from here?
Yes, please.
Shall I do it from here?
Yes, sir, you need to share.
Yeah.
Please, you can share your.
If you switch off, then I.
Yes, sir, please. We're giving you the control. Kindly share your screen.
Okay. Oh, wonderful. Can you see this now? Hello?
Yes, sir, we're waiting. Still, I guess it's loading or.
Okay.
Okay, sir, we can see your screen.
Okay, wonderful.
Yes, sir, perfect.
Hopefully it works now.
Yes, sir. Please carry on.
Okay. So I'm sorry for this trouble. So this slide shows how Bangladesh has sort of improved in terms of poverty alleviation as represented by GDP per capita. So apart from Sri Lanka, Bangladesh now has the highest GDP per capita in South Asia. Also Bangladesh has done quite well in primary schooling and in terms of net enrollment at the primary level, as you can see, that Bangladesh has done quite well and it's at par with India, but it's still much behind Sri Lanka. So this is the gender gap index, which has been used by many, which is a kind of a composite indicators of economic participation and opportunity, educational attainment, health and survival, and political empowerment. So all these parameters, this gender gap index is calculated. And here also you can see that Bangladesh has done quite well, and it is quite close to what for example, a developed country like the UK has. Here also, Bangladesh has surpassed Sri Lanka as well. Now, in terms of the health outcomes, life expectancy, Bangladesh now has the highest life expectancy in South Asia, apart from Sri Lanka. And in terms of infant mortality also, Bangladesh has done quite well. In terms of maternal mortality, Bangladesh also has done well, but Pakistan has also done well. But this morning I was listening to Fareed Nad, and he was saying that the latest Pakistan figure is about 170 something, so which is very close to what Bangladesh has now. In terms of some of the health systems indicators, in terms of immunization, for example, Bangladesh has almost near universal immunization, and Bangladesh has moved quite fast on these. In the mid 1980s, only 2% of Bangladeshi children were immunized. But within a few years, Bangladesh has actually sort of moved into a very high immunization rate. And interestingly, it has really sustained that over the years. In terms of the use of oral rehydration, Bangladesh has the highest use rate in the world. 85% of the diarrhea cases are given some form of ORT. Also in terms of sanitation, as you can see here, Bangladesh has done well also over the years. This one shows the progression in terms of the total fertility rate and also the contraceptive prevalence rate. Here is a correction. The CPR is actually per 100, not 1. Yeah. And as you can see that the total fertility rate has gone down continuously since 1970, and at the moment Bangladesh has about 2.3, which is very close to the replacement level. Along with that, the contraceptive prevalence rate has also increased. It's over 60% now, which is quite significant for a Muslim country. Population growth rate also, Bangladesh has a population growth rate of 1%, which is sort of only Sri Lanka has 0.5% growth rate. Now also we just had the it is still there, of course, the COVID pandemic, and recently the Nikkei they did a kind of a COVID recovery index, and according to the Nikkei recovery index, Bangladesh is well ahead of the South Asian countries in terms of the recovery, and also globally Bangladesh is the fifth in the long list of over 100 countries in terms of the recovery. Now Bangladesh's sort of improvement has been looked at by many of the famous people, as you can see here, Dr. Hasan, the editor of the Daily Telegraph for India, also the Lancet, and also a columnist at the New York Times. And they have been saying very good things, of course, about what Bangladesh has done and what the global community has to learn from it. Now the question is, what has happened in Bangladesh that despite poverty, Bangladesh in the 80s, about 60% of Bangladeshis were poor by any standard, any definition. This has gone down to about 22% now, but that still means that about a quarter of Bangladeshis are still poor, which is about 40 to 45 million people are literally poor in this country. Also, in terms of the inequality of income, the Gini index is one of the worst in this part of the world. But despite these negative things, what has happened in the country which has really helped Bangladesh to move forward, particularly in the social development field? So we have some sort of hypothesis here, and we feel that the war of liberation had a huge impact, particularly in changing the mindset of the people. Also, this also brought many changes in the constitution, and also this led to the rise of many of the most successful NGOs in the country. Also, there have been very large number of public health actions at scale, which was done all over the country. So, for example, even as early as 1980, Bangladesh formulated the drug policy, which was kind of a very revolutionary thing, and that brought the price of the drugs very low, so that people had more access to essential drugs. Also, there has been a large number of public health miracles that happen in the country. As I was showing, the family planning has done quite well in this country. Also ORT and immunization, and also the directly observed therapy for short course for tuberculosis. And also water and sanitation, Bangladesh has done quite well. And the interesting part is that this has been done not only in one district or 5 districts, but it was done all over the country. So scale was an important thing. In terms of poverty reduction and the food production, as I said, that the poverty has been reduced from 60% to 24% over the last few decades, but the food production has actually trebled, which means that while the population doubled, the per capita availability of food has increased quite significantly. And since the 70s, when we had a big famine in this country, which killed thousands of people, we haven't seen any such food shortage in the country since the 80s. So this agricultural revolution has played a very important role also. In terms of the natural disasters, as you know, that Bangladesh is a country prone to all kinds of natural disasters, floods, cyclones, drought, and so on. And just to give you one example, in 1970 there was a huge cyclone in the coastal belt of Bangladesh, which killed about 500,000 people. But because of the different actions that has been taken to counter that, the number of deaths from cyclone has come down significantly. There was a similar kind of cyclone as 1970 a few years ago, and only a few dozen people died. This was a big sort of a change that has happened in this country. Also, the private sector has also flourished. You may have heard about the ready-made garments industry. Bangladesh is the producer, is the second largest producer of ready-made garments in the world after China, which employ about 4 million workers, and most of them are women. And the garments industry is a mainstay of our economy. About 15% of the GDP comes from that. So the private sector has been flourishing over the years. The pharmaceutical also, we are self-sufficient in pharmaceutical, and we are also exporting it to about 100 countries. Empowerment of women is a major thing that has happened since the independence, and the economic participation of women has risen tremendously. Also, the microfinance borrowers, almost all the microfinance borrowers, which number about 25 million, are all women. Also, the health workers, the frontline health workers, are mostly women. For example, BRAC, the NGO, has about 100,000 community health workers, and all of them are women. So that has brought healthcare very close to the people, particularly women in the rural areas. And also we have, as I said earlier, that Bangladesh has almost near universal girls' education. Also, Bangladesh is a kind of a NGO country, which is a direct result of the 1971 war. And what has happened in this country is that, unlike many other countries, that the state has actually created the space for NGOs to innovate and also to scale up. And there are many examples here where the government and NGOs work very closely in implementing development program. And just a few words about one of the largest NGOs in the world, which is BRAC, for which I used to work. And BRAC is the largest NGO now in the world, which is also present in 11 other countries. It has actually sort of made huge impact on the development of the country. Now, to the future, we have achieved that. As I said, that there is no room for complacency, and we have done better than some of our neighbors. But we also have some neighbors who are much better than us already. For example, Sri Lanka. And if you compare infant mortality with Sri Lanka, you can see that Bangladesh has about 33 per 1,000 live births. But for Sri Lanka, it is only 6. In terms of maternal mortality, Bangladesh has 176. But look at Sri Lanka's maternal mortality ratio, which is 30. And also the primary school completion rate for girls. Here also, it is almost universal for Sri Lanka, but Bangladesh has to go a long way towards that. So these are some of the reasons why we have to really think about the future, that we should not really be complacent of what Bangladesh has done, but we have to look forward and see when we can sort of beat Sri Lanka in these indicators, and that's what the Bangladeshis are working towards. Now, finally, as we have heard in the previous presentations on Pakistan, by the way, those presentations that I heard were excellent presentations about the situation in Pakistan, and I was so pleased to listen to them. Now, about the challenges towards the SDGs, there are many challenges that we have to think about. There are new emerging issues coming, the non-communicable diseases, cancer, diabetes, and so on. The urban problem becoming more and more a huge issue here in this country. Now we have about 35% of the country urban, but it's going very fast. And but unfortunately, we don't have a serious plan for urban development, particularly the health sector work in the urban areas. Climate remains a major issue, and also the road traffic accident and so on are kind of issues that we have to deal with in the future. Malnutrition remains a major issue, but a third of Bangladeshi children are stunted. This is very shameful for a country in this 21st century. Also, the high out-of-pocket expenses, 66%, which is one of the highest in the world. So that's a major problem that we are facing, and we don't see much activity on the part of the government to really sort of address this particular issue. And we know that as I was presented in a paper this morning on Pakistan, that health shocks are sources of people becoming poorer and poorer. And in this country, in Bangladesh, about every year, about 2 to 3% of the population become poor or sort of turn into poverty because of health shocks, because of health expenses. So this has to be tackled very well, and also as soon as possible. Bangladesh invests very sort of poorly in health. Less than 1% of the GDP is spent by the government on healthcare.
Thank you, sir, for highlighting these areas and the areas. Sir, Mehtab Karim would like to say thanks.
Dr. Mushtaq, thank you very much for being with us right from the morning. And it's really a great pleasure hearing the miracle of Bangladesh, and you have been one of the pioneers in the program. Can you stay with us for a while? We have a presentation from Iran, and then we will open up for question and answers.
Sure, sure.
Is it okay with you?
Yeah.
Okay, thank you. So we'll have Dr. Amir Hussain from Iran. Thank you very much, Dr. Mushtaq.
Thank you.
Okay.
Next honorable speaker is Professor Dr. Amir Hussain Takian from Iran. Dr. Amir Hussain is a full professor and department head of Global Health and Public Policy and Vice Dean for International Affairs at School of Public Health, Tehran University of Medical Sciences. Since December 2021, he is a founding council member of Worker Foundation for Global Health Germany and advisor to TMS Chancellor in Health Policy. He is a member of National Examination Board for Health Policy, Economics and Management and at the Ministry of Health and Medical Education, Iran. He is the Chief Research Officer at Health Equity Research Center and Head of TMS Office for Alliance and Collaboration, serving as a member of World Health Summit Executive Committee since 2017, Secretary of 7th World Health Summit Regional Meeting 2019. From 2013 to 2018, he was Deputy for International Organization at MOHME, Iran, that is Ministry of Health and Medical Education, overseeing the relationship between Iran and global organization, that is WHO and UN. Dr. Takian is elected member of National Academy of Medical Sciences and National Committee for Prevention and Control of Non-Communicable Diseases. A physician by training, has a track record research and health policy analysis in the field of good governance, evidence-based policy making, global health, non-communicable diseases, universal health coverage, and e-health. Published over 135 peer-reviewed journal articles, 21 books, 5 book chapters, and 19 commissioned national and international reports. Dr. Takian has been a principal investigator in several collaborative research projects at national and international level with a value equivalent to over 7 million euros. He has supervised over 39 MSCs and 42 PhD students and has been invited as a keynote speaker in global events at United Nations, WHO, World Health Assembly, World Health Summit, PMAC, and frequent TED speaker. So he was awarded the Best Educational National Award of Iran in the field of medical sciences in 2017, the Global AMEE Award in 2018, Best Teacher Award of SPH TMS in 2019, and Joint International Figure of TMS and Tehran University in 2019 and 2021. So it's a lifetime fellow of Higher Education Academy of UK. I would like to invite Professor Dr. Amir Hussain Takian and highlight the challenges towards sustainable health development in Iran. Sir, please would you continue with your topic? Thank you.
Thank you very much, ma'am. And can you hear me well?
Yes, sir, you're audible. Please continue.
Okay. All right. Thank you very much for having me and for the very detailed and thorough introduction. It's my great honor and pleasure to be with my colleagues, friends, and collaborators in Pakistan. Pakistan is very close to us in Iran, and I have been very honored to travel to your beautiful country several times in collaboration with the universities in Karachi and Islamabad. And when Professor Karim invited me, I thought what a great opportunity to go back again, this time virtually, to share with you some thoughts about poverty and the role of poverty in sustainable health development in my country, and bringing some little experiences from Iran. So that's why I thought I will speak about the poverty and what it means and why it matters for sustainable development, and then bringing the experience of public policy and then specifically health policy in the Iranian context with you, and then some big challenges we have been facing. If you look at Sustainable Development Goal number 1, ending poverty in all forms everywhere is the issue. So there are some targets: eradicating extreme poverty, reducing poverty, social protection schemes, and equal right to ownership, basic services, and many other goals to be followed. Poverty has a great root in social determinants of health, and if you look at health gradients of poverty, you can see that poor housing, unemployment, inadequate food, lack of education, and environmental health hazards all affects poverty, and poverty affects health. Talking about Iran, some basic indicators, you can see that we are a country of about 84 million, so something like 1/3 of Pakistan. And then in terms of health indicators, maternal mortality, neonatal mortality, we are somehow not very bad compared to the international benchmark. And we are the country that since 2015, I will come to this in a minute, we have been spending about 9% of our GDPs on the health system. So you can see that we are not doing that bad. But when you look at the position of the country worldwide, specifically when you look at the ecological threat register in 2020, you can see that along with some other countries in the region, like Pakistan, we are among the top 20 countries with most displaced people from disasters. Like Pakistan, we are facing floods, many natural disasters. We are facing refugees and dust storms and climate change issues. And that's why Iran is, we can see here, we can see your country, we can see Iran and many countries in the region. We are in a very bad situation in terms of the natural threats, which somehow affects our national security. If you look at poverty, and the progress about SDG number 1, you can see Iran has done not that much bad, but there still remains some challenges. When you look at poverty as the headcount ratio of less than $2 a day, Iran is okay. So we have achieved the goal. When you have $3.20 a day, still we have some challenges. So you can see we are running really not very good in terms of poverty eradication. My first point today is why poverty matters and why my colleagues, Professor Mahtab and others, have somehow emphasized on poverty elimination as one of the main pathways to reach sustainable health developments and universal health coverage, as Professor Mushtaq mentioned in the end of his presentation, which is one of the big challenges in our region. If you look at this study, you can see that poverty and sustainability, and specifically poverty and SDG number 3, which is health and well-being for all at all ages, have a very synergetic relationship. So perhaps the most synergetic relationship between poverty and other SDGs is between poverty and health, because, as I said, health is very related to other social determinants. Looking at the Iranian experiences, in the course of last 4 decades after the Islamic Revolution of 1979, we have had a number of 5-year national socio-economic development plans, and we have just finished the 6th one, and now we are starting to prepare, actually to conclude the 7th National Development Plan of Iran. In those upstream policies, there are some initiatives to reduce poverty and empower citizens. For instance, identification of vulnerable groups and target groups in poverty education programs, institutionalization of food security and improving people's nutrition and community health, supporting the vulnerable groups for access to public health, public education, minimum shelter for everyone, and empowering specifically rural and deprived areas to eliminate regional imbalances. I will come to that in a minute, that in Iran, we have a big gap between the rural residents and the urban residents, and given the fact that in the course of last 4 decades, Iran has had the majority of its citizens residing in urban settings, this has brought lots of challenges. Entrepreneurship developments for the poor and low-income groups, like what BRAC is doing in Bangladesh, and targeted subsidies, which I will mention specifically, and then establishment of the comprehensive social fencing system for the citizens, specifically the poor. One particular initiative which I want to emphasize is the Iranian welfare database. Since February 2013, we brought all together 50 different data sources, and we created welfare economic identity of individuals, which is aiming to systematically identify and outreach the vulnerable economic groups. The aim of this is identifying the school dropouts, improving the food basket distribution mechanisms, eliminating insurance overlaps and inefficiency, and launching comprehensive health insurance, and design and modification of social insurance processes for some specific labor and workers, and identifying the poor and providing support packages for the poor. These are the things that we have been doing. The second initiative, which we have been running since 2009, and just yesterday there was a big change in this program, is targeted subsidies. Targeted subsidies means that because Iran is depending on the oil revenue, and we are an oil-rich country, so since 2009, the government decided to do a big surgery on the economic situation of the people. So they took out the subsidy on the fuel and other materials, and then they paid cash to the citizens directly, which was at the time was not that much bad, but I will come to that now it is not making a kind of difference. If you look at the Iranian figures compared to other countries in the region, you can see that the share of population in extreme poverty in Iran is very low, perhaps less than 1%, which is in par with Turkey, but compared to Egypt and the Middle East and North Africa is much less. When you look at the number of people, you can see that in terms of number, we have less than 600,000 population, and this has been increasing in Iran, whereas in some other countries this has been increasing. But the challenge, which is my third point, and I would like to emphasize on this, is income inequality. So extreme poverty is not that much, but income inequality and Gini index has been somehow consistent. And now, after somehow improvements, we are going back to not a very promising situation again. The point is, there is no established official poverty line for Iran. So poverty is measured using international poverty lines, which is expressed in US dollar, and using the upper middle income class line of $5.50 a day. In Iran, between 2009 and 2013, we faced 5 percentage points to decrease to about 8%, before increasing to 10.9, almost 11% in 2017, when access to education and basic infrastructure are considered, in addition to having daily consumption less than 1.90 per dollar. Multidisciplinary poverty in Iran remains lower than 1% in 2017. And you can see that the poverty is not that much in the multidisciplinary approach. And when you compare the inequalities with some countries like South Africa and Brazil, you can see that we are running better. And we are in par with Turkey, which has a higher GDP per capita compared to us. But again, the inequalities remain a big issue. Now, let us have some words about the health system in Iran. This is important to understand because in Iran, we have a kind of unique governance of the health system. Perhaps we are only country in the world in this scale. We have integrated our medical education into medical service. And this is the organization of the health system. We have medical universities, almost 70 public and more than 100 private medical universities, all affiliated with the Ministry of Health and Medical Education. And then we have some other organizations like the Ministry of Welfare, the Ministry of Defense, the Imam Khomeini Foundations. They work in collaboration with the Ministry of Health and the insurance organizations in order to provide services, purchase the services. And one point is, we have been enjoying a very comprehensive and extensive primary healthcare system in the course of last 4 decades, which has made Iranian health indices comparable to the world. One of the main points about, and in this paper, we have somehow described all these reforms in the Iranian health system. And one of the main points for reducing poverty and empowering citizens is using the primary healthcare system for strengthening marginalized, poor, and suburban regions, and defining a kind of functioning social fencing system for less developed areas and allocating more human resources for health, like the physicians and nutritionists and mental health specialists in those areas to serve the people. Our PHC network is very comprehensive in rural areas and in marginalized areas, and I will talk about a little bit about that. And this, along with other things, has contributed to the key health status indicators in Iran, like maternal mortality ratio or under 5 mortality ratio, and which is now, we have passed and we have surpassed SDGs. And if you look at, for instance, the death rate to road traffic injuries, we are not that much good. And if you look at this skilled birth attendance in Iran, you can see that almost the entire birth attendance in the course of last 25 years, we have had a very, very good situation. And then when you compare it, Iran, which is here in red bar, with other countries like the Middle East and North Africa and other middle-income countries, you can see Iranian function is not that much bad. And then when it comes to other ratios like infant mortality ratio and child mortality ratio, again, this is Iran. Our progress has been promising in the course of last 4 decades. But one point, which is my 4th point today, which before I come to the conclusion, is health inequalities. And this health inequalities has contributed a lot into poverty. So if you look at the Iranian household, you can see there is a huge difference here, for instance, between the rural areas and the lower quintile and the highest quintile of the population in terms of the health expenditure. One fact which has remained constantly a challenge is health inflation is much higher than the general inflation in Iran. And then when you look at, for instance, Kakwani Progressive Index, you can see that health inequality is not very promising, and Kakwani Index, which is one of the indices of health inequalities, remains an issue. So we have been facing challenges to provide sustainable strategies to reduce inequalities in healthcare expenditure in my country, and that's why we can say, for instance, if you look at there is a Persian cohort study looking at the mental health of the Iranian population. In terms of mental health, we are in a very bad situation. And if you look at the subnational data, you can see that across the provinces and between the rural and the urban settings, the burden and the access to medicine and healthcare for mental health services is not transparent, it is not coherent. When you look at one of the most vulnerable groups of the citizens, who are the people with disability, we published, actually one of my PhD students did his thesis on health policy analysis of financial barriers for health services for people with disability in Iran. And we found that, unfortunately, health insurance and the affordability for low-income people, and specifically for the families of people with disability, transportation costs and things, for those people is alarming in the country. And unfortunately, the case worsened during the COVID pandemic in my country. So as you can imagine, we had some huge health challenges until 2014. And unfortunately, again, after 2018, we have been facing those challenges, like incomplete and effective insurance coverage, very high out-of-pocket. We reached sometime about 60% out-of-pocket payment, which was really shameful for my country, inadequate access to health services, specifically in remote areas, and undesirable citizen satisfaction and inadequate health workforce and unrealistic tariff plans. So that's why in May 2014, actually now it is the 8th year, it was on the 5th of May 2014, we started our comprehensive health transformation plan. There is a book published by the Voters Organization, which I had the honor to be one of the editors of the book. We have somehow described the story of our health transformation plan in Iran, but we aim to address these challenges, to gap these bridges, like sustainable financing, financial risk protection, specifically for the poor, and increasing equitable access to quality health services, and increasing people's satisfaction. So we started a series of reform, and as you can see in WHO report in 2019, Iran here is one of the few countries back in 2019 followed scenario number 1. You can see here that health financing transition in Iran is very promising compared to many other middle income countries. This means that Iranian government expenditure increased from 5.6% to almost 9.1% from 2014 to 2016. And another thing was health priority. Ma'am, shall I finish? Okay. All right. So, and another point was the health priority increased and for the government, so we had a very promising political commitment for health. Many initiatives started, like, hello, can you hear me?
Yes, sir, you're audible. Please continue.
I can hear you. Is there any issue?
No, sir, thank you. Please continue, you're audible.
Okay, all right, good. Thank you very much. I try to finish in a few minutes' time, if you don't mind.
Yes, sir, please, thank you.
Thank you very much. So if you can see, these are some initiatives we did during our health transformation plan. So you can see that we strengthen our primary healthcare system, specifically to reach the vulnerable and marginalized people. Lots of plans for monitoring, lots of plans for empowering citizens, intersectoral collaborations, increasing access to medicine, a very comprehensive plan, for instance, which I show it here, a very comprehensive plan for prevention and control of non-communicable diseases. These are different campaigns we have had for smoking cessation and access to medicine and different things. And empowering the family physician program, self-care, NCD screening, and new packages, and many other things that we started to have. And specifically, one of the vulnerable people, group of vulnerable people in Iran are refugees and immigrants. We have millions of refugees from Afghanistan, and in the course of last 4 decades, we have, and specifically after the new political changes in Afghanistan, now we are the host of more than 5 million Afghan refugees in Iran. Health transformation plan, which we have described in this article, and these few articles which I've showed here, we have provided for Afghan refugees those medical services, education, literacy classes, alike with Iranian citizens. So you can see that Iran is facing double burden of having the huge number of Afghan refugees, having the sanctions against the country in the course of last 4 decades, and specifically since 2018, the unilateral US sanctions as well. We did a number of studies. I shared with you some papers which have been involved in that, and lots of reports to see the effects of health transformation plan, and those effects you can see are promising. For instance, the total health expenditure on GDP increased, and it reached 9.5%. Public expenditure on health increased, and that's why out-of-pocket payment decreased dramatically, and insurance coverage increased, promising as well. And as just one example, you can see these ended in when COVID-19 happened, in enjoying the comprehensive insurance package that we had. The out-of-pocket payment for treatment of COVID-19 in Iran, given the fact that Iran was one of the most heated countries in the region in terms of COVID-19, remained about less than 9%. So you can see that the government subsidy for even expensive drugs and vaccination was really, really comprehensive. So that's why this is one of the things which protected the poor. But unfortunately, at the same time, if you look at the impact of targeted subsidies in my country, which started since 2009, you can see that this is on the right-hand side, you can see that the red bar is after the targeted subsidies since 2009, and on the green bar is before that. And this is access to calorie intake. You can see that, unfortunately, from 3,200 calories a day, we have reached less than 2,800 a day. So we can imagine that, unfortunately, that the subsidies has not been that much promising. This is my penultimate point, which is very important, and I'd like to share with you this information, which is very important to understand. National numbers unfortunately hide the stark urban and rural differences in poverty indices in Iran. If you look at the upper side graphs, you can see that there is much higher rural poverty head count rates of about 27% compared to about 6% in urban areas in 2017. And this was before the US sanctions, this was before the COVID-19 pandemic. Iran has not been successful in terms of inequalities. Inequalities measured by expenditure per capita Gini index fell sharply between 2009 and 2013, as you can see here, but unfortunately from 30.2 to 37.4%, but again increased to about 41% in 2017. So this shows that Iran has not been successful to sustain positive growth in per capita expenditure for the bottom 30% of this population during 2014 to 17, despite expressing positive economic growth. In fact, the bottom 40% experienced a negative growth rate of almost 0.13% over this period, while on average consumption increased by about 2%. This outcome is very important to understand. If you look at the lower chart here, because this, due to the erosion in real time of universal cash transfers of targeted subsidies, it was unable to compensate the increasing energy prices after the subsidy reforms. Cash transfers were instrumental to reduce poverty during 2009-2013, but because of high inflation, and specifically for the poor, and specifically for the health inflation, the real value of benefits diminished. So given the much larger share of transfers in the budget of poor households, negative impact from falling transfer for them was stronger than the slight poverty reduction efforts coming from the labor market. And unfortunately in 2020 and 2021, due to the COVID-19 crisis, increased gas prices in 2019, and economic downturn poverty due to the sanctions, specifically since 2018, this expected to increase, but the overall magnitude will depend on the policies to follow. So you can see that we are facing huge challenges in terms of years to come. We have main challenges in the health system, like embedded inequality, still high out-of-pocket, and lack of standard practices in the country. And one of the huge and big challenges which remain is the aging population. This is my last slide. If you look at 2013, at the moment, the over 60 population ratio is about 15%. We think by 2030, it reaches to about 20%. Then we think that the alarming situation is here. By 2050, almost 50% increase of the health system expenditure will be about aging. And this will push people to poverty unless we can create sustainable resources, not just in the health system, in our pension system, and in the health budget expenditure from the government to increase the poverty. In the nutshell, what I would like to share with you are these three lessons. Iran has been doing well in terms of health system outcomes due to a very comprehensive primary healthcare network, and since 2014, health transformation plan. The second point is we have had a number of national development plans to tackle poverty and reach sustainability and sustainable health development in terms of empowering citizens. But unfortunately, due to externalities and due to some kind of failed policies, even the targeted subsidies has not been that much successful to protect the poor. So we can see that the decrease in calorie intake and nutritional requirements for many people, specifically in the poor, and specifically for marginalized and rural areas. And the last but not least, our pathway towards universal health coverage and sustainable health development remains challenging in post-COVID-19, specifically because of the inflation, a global inflation in food prices, the global inflation in gas and petrol prices, and many other fundamental things. Unless we can have a good policy which is robust enough to protect the poor citizens, given the fact that Iran is dramatically aging, we will be facing huge challenges towards universal health coverage and protecting the citizens, specifically the poor, which needs very urgent attention. With that, I would like to stop here. Thank you very much for giving me this opportunity. I hope I provided a kind of very basic picture of our efforts and initiatives in Iran to address poverty, the successes we have faced, and lots of challenges are still ahead of us. Thank you very much. Over to you.
Thank you, sir, for taking out. Okay. Thank you, sir, for taking out your precious time and sharing with us your treasure of knowledge and profound information. The forum is open for questions from our reputable speaker, Dr. Mushtaq, and Professor Dr. Mir Hussain.
I'm the president of SZABIST, and on behalf of the management of SZABIST, I would very much like to thank Dr. Mushtaq Chaudhry from Bangladesh and Dr. Amir Hussain Takian from Iran for their exceptional presentations telling us how transformation has taken place in both your countries. Pakistan, as you know, still faces enormous challenges. And there has been, of course, a great deal of analysis as to why we are particularly in this deficit situation, both in terms of our health, family planning, and education sector outcomes. But both Bangladesh and Iran are role models in terms of management of the health systems, in terms of financial support, percentage of GDP, the other areas that impact on the health sector, such as girls' education, women's empowerment, women's participation in the labor force, etc., and in terms of governance and structures and systems that obviously are built for transformation and for effective delivery. So I just wanted to say that both your presentations were really exceptional, very relevant for us to learn from, full of very significant data sets and analysis, and clearly situating how you have undertaken reforms in terms of health sector outcomes, which you presented today. These are, I think, pathways that even we need to look at in Pakistan, because in many ways there are similarities between our three countries, and there are, of course, stark differences, both geographically, spatially, the cultural milieu, the political context, and other issues which are connected to our location. I'd say regional geopolitical location. But I just wanted to thank both of you. I have listened with great keen interest, and so have our students and our faculty from the Department of Public Health and Life Sciences. And we have recorded your lectures, so some of our students who were not able to be here today, they will be listening to your talks and seeing your presentations, hopefully, during some of their class sessions over the next 1 or 2 weeks. It is by coincidence also that our Chancellor, who is the Health Minister for the government of Sindh, Dr. Azra, happens to be in Tehran right now. She's visiting Iran. And so we were looking forward to her returning and sharing with us information about your health system. But Dr. Amir Hussain, you have already told us a great deal. So I think when she comes back, we will have a lot of information from you already, and we'll be able to have a much deeper discussion with her. So I just wanted to ask one question. I know we are running out of time. Do you think that having some, in terms of government structures, the placement of the medical universities under the Ministry of Health Has it always been like that, or has this been part of the health transformation plan? Because in many countries, medical universities are not placed under the health ministry. But it seems like it has worked well in Iran. Was that the situation several decades ago, or is this something that is part of the major reform and transformation plan?
Thank you very much for your sentiments and for giving us this opportunity. And I would like to thank Dr. Mushtaq as well, which I learned a lot from Bangladesh, to be honest, and it's always good to share the experiences. And I'm happy that your minister is in Tehran. I will make sure that I can reach and share some information if possible. As you know, Iran has had this integration of medical education into service, meaning that moving the medical universities under the Ministry of Health since the early 1980s. So it's about 36 years now, since 1984, that we did this. The reason for that was, for instance, I remember when I was a teenager, say 30 years ago, 25 years ago, then I went even to the affluent areas of Tehran to visit a doctor. We didn't have enough Iranian doctors. And we did have many doctors, many of whom from Bangladesh, Dr. Mushtaq, and from Pakistan, practicing in Iran. And let alone, if you go to remote areas of Iran, we didn't have access to doctors and other practitioners, so we were suffering from the lack of human resources. So the government decided to do this comprehensive reform and move in order to use all available resources for training human resources for health, decided to move the medical universities from the Ministry of Higher Education and Science to the Ministry of Health at the time, which became the Ministry of Health and Medical Education afterwards. So to be precise, answering your question, this has been running continuously in the last 4 decades almost. We have had a number of evaluations of this because this initiative is unique for the country as big as Iran, for the size of 85 million population. So we have had a number of initiatives and evaluations from the World Health Organizations, from the Medical Education Global Medical Education Federation. We have invited many people. The initiative has strong opponents within Iran. Some were accusing the conflict of interest of doctors to want everything for themselves, you can imagine, but still continues because we have a strong evidence that this has contributed to training and preparation of massive army of medical professionals and doctors, nurses, midwives, and others. And the second thing is because of having all medical education, service, research, Food and Drug Administration under one roof, we have been somehow collaborating in more efficient way in order to use our resources for the better public health. Having said that, my last point is this. I don't think myself that the same system as it has been in the course last four decades of thing, without massive reforms in terms of good governance, like bringing down the conflict of interest, more transparency, the use of evidence in medical and public health decision making, and accountability, responsiveness, and the involvement of the public in decision making. This is one of the things which I'm really hoping for Iran and other countries to happen, like what Thailand is experiencing, bringing public into the heart of decision making. Just one very important example is non-communicable diseases. Like Pakistan and many other countries, 80% of our population die from non-communicable diseases. All are preventable and very expensive. In order to reach out the population and encourage them for self-care, there is no other way to do this because we don't have enough resources to tackle and to pay for these very expensive diseases. That's why we need to bring people into the decision-making, empower them, and make them feel the ownership of the health system so they do look after themselves. So that's why I think we need to have big reforms in order to make that happening. But yes, we have been having this, no discontinuity so far, and still that's the case. And I'm sure your minister will be exposed to this kind of reforms to see that if it didn't happen, please ask her to go and ask for to visit some of our primary health care centers and some medical universities to see this integration and see what happens. Myself, I am a medical doctor. I am a professor at the university, and at the same time, I'm the executive at the Ministry of Health. So many of us have these different hats. This brings some advantages because we are at the very first touch of the health policy making. So when we go to the classrooms to teach our students, we bring the first-hand experiences to our students. And on the other hand, this brings some challenges as well. So I leave it there for the minute.
Thank you. Thank you. Thank you very much, Dr. Amir Hussain. Excellent presentation by both of you. This is Mehtab Karim, and I have one quick question. I'm sure that there will be many other questions coming, but we have within 10 minutes or 5 minutes a speaker from Indonesia. But I have questions from each of you. Maybe you can answer in very quick succession. What can Pakistan learn from the experience of Bangladesh and Iran? Okay, thank you very much.
Dr. Mushtaq, please go ahead. I'm keen to listen to you.
Can you repeat the question, please?
Okay, just a second. Well, Mushtaq, you know that my question is that we have been working together on this paper. What Pakistan can learn from the experience of Bangladesh? How much the policy adopted by the country, each of the two countries, have affected the healthcare system in the two countries, and obviously the reduced population growth rate. So, Dr. Mushtaq, the first question is from you. Yeah, first from you and then from Dr. Amir Hussain. Thank you.
Okay, thanks, Mehtab. I think there are a few things which sort of distinguishes Bangladesh from other experiences. One is that Bangladesh at the first stage decided to harvest the low-hanging fruits, which can be done very easily. So ORT, immunization, family planning, the water sanitation, and so on. And so they decided that they want to do these and at a scale and with good quality. So that has been done well, I think. So that has been done, and also that secondly that obviously the other question is whether you are able to reach the poor people, and because of the involvement of the NGOs who work at the grassroots level, who work with the people directly. So the fruits of these interventions have been able to really reach the poorest and disadvantaged people. And thirdly, that we know that a change in health status doesn't only happen because of the health intervention, but about 60% of the changes are actually happens because of the interventions in the social determinants of health. So for example, education, women's empowerment, poverty alleviation, and also even infrastructure development, roads and waterways and so on. So these, I think these are the things that can quickly explain why Bangladesh has done well at the first instance. But obviously, in order for us to move forward, we have to think about the higher hanging fruits, the things which won't be easy to do. For example, the NCDs. And in order to do the NCDs well, obviously you have to have a good health system. And we know that there are a lot of problems in the governance and also the management of the healthcare system in this country. So unless we are able to fix those and also make healthcare available to the poor through a system of universal health coverage, it will be very difficult for Bangladesh to reach to the next stage of health innovations and health outcomes. Thank you.
Okay. Thank you, sir.
Thank you very much.
That's all from your
Yes.
side. Now we'll be taking our last international speaker. Sir, Dr. Awazariman, would you like to comment briefly?
Just to respond to Professor Mahtab, very, very quickly, as you know, Iran and Pakistan are two absolutely different health systems in terms of decentralization. You have the Ministry of Coordination and Regular Services, and in 4 provinces of Pakistan, you have the federal system, and those provinces are very important. Whereas we have in Iran very centralized system. This makes some challenges for Pakistan much more than Iran. For instance, in your Sehat and Suhulat program, which is the pathway towards universal health coverage for the poor, or for your NCD program, the issue that applies to the entire population is the decentralization. One way to do that is having a national committee for coordination and specifically for intersectoral collaboration. One lesson that I can share with Pakistan is in Iran, we have a national committee, which is a Supreme Council for Health and Food Security, which brings all the policies aligned with each other for intersectoral collaboration. That's one issue. The second thing is having a strategy for after COVID era. COVID-19 has brought many challenges and has somehow highlighted the importance of climate change and other extra health sector factors, for which we need to have one very defined strategy. Otherwise, those challenges will be affecting the health system and the health outcome of the population very dramatically. So that's why this is one of the experiences that we have in Iran, which helps us. I would suggest, given the differences in Iran and Pakistan and the decentralization that you have, you can exercise that. And finally, one point is, another lesson that we can share is we need to have a kind of defined strategy for our priorities. In Thailand, one of the lessons that we learned was Thai people say, we are not that much rich not to have universal health coverage. Because your students are there, I want to repeat that. We are not that much rich not to have universal health coverage. That's very applicable to your country, and I think we need to somehow work on the politicians and healthcare policymakers to make them understand universal health coverage is not a luxury. Universal health coverage happens when we don't have enough money. Otherwise, all efforts towards tackling non-communicable diseases, tackling the future pandemics and things will be failing. Thank you very much.
Thank you, sir. So now we'll move on towards our last international speaker. Last speaker we have from Indonesia, Dr. Teguh Dartanto. He is the Dean, Faculty of Economics and Business, University of Indonesia. He was formerly Vice Dean and Head of Department of Economics, Indonesia. Dr. Teguh is also head of cluster research on poverty, social protection, and development economics in the same department. His expertise lies in poverty analysis, social protection, development economics, and health economics. His research has been published in numerous journals, including Lancet, Applied Health Economics and Health Policy, Economic Modeling, Tobacco Control, Tobacco-Induced Diseases, Nicotine, Tobacco Research, and World Development Perspectives, International Journal of Environmental Research and Public Health, Vulnerable Children and Youth Studies, Bulletin of Indonesia Economic Studies, Energy Policy, and Singapore Economic Review. He is actively engaged in research collaboration with domestic and international counterparts such as GPL, Southeast Asia, AMU, ADB, UNDP, GIC, and OECD. He is now appointed as Indonesia representative at Governing Board of Economic Research Institute for Asian and East Asia. Prior to that, he received a scholarship to pursue his Master's of Economic degree and PhD in International Development at Nagoya University. I will welcome Dr. Tegu to shed light on national health insurance and its contribution to poverty, life expectancy, and productivity in Indonesia. Sir, please share your screen.
Okay, good afternoon. Assalamualaikum warahmatullahi wabarakatuh. I'm the Gudatando. Is my voice is clearly here?
Yes, sir, you're audible, just a bit louder, I hope. Okay. Yes, sir, please continue.
Okay, thank you very much for Ms. Samira. Today, as I mentioned, I'm the Gudatando, the Dean of Faculty of Economic and Business University Indonesia, and also Head of Research Cluster on Poverty, Social Protection, and Development Economics in our faculty. And I would like to talk about the issues on the national health insurance and its contribution to poverty, life expectancy, and productivity in Indonesia. And thank you very much for inviting me as a speaker for this event in the Life Science International, the first Life Science International Conference in the second day with the topic of the poverty and the public health issues in Pakistan and other Muslim countries. Indonesia is one of the biggest Muslim countries in the world, and maybe have the good experience for sharing about the public health issues. Today I would like to talk about the national health insurance and its contribution to the poverty, life expectancy, and productivity in Indonesia. As we know that the universal health coverage is one of the public health issues that gain attention not only for developed countries, but also for developing countries. Universal health coverage that is achieved by national health insurance is also part of the Sustainable Development Goal number 3 that ensure healthy lives and promote well-being for all at all ages. Developing universal health coverage through national health insurance program is one of the solutions to improve access to health care, as well as reduce the household burden for health expenditure. But many people think that the country has to have enough money first to develop universal coverage. So many people think that we have to have money first and then we concern with the public health. But at least based on the Indonesian experience, this is not really necessarily correct. So our Indonesia experience in developing universal coverage by integrating the fragmented system into the national health insurance system is not a big bang reform. It's not a one-shot reform program, but it is gradually developed. Indonesia, with the long period of the periods of the colonization, and also Indonesia having the fragmented system of the health insurance, the government's provided health insurance. This study was published in our paper in the Lancet in 2018, that we provide that this is the historical perspective of Indonesia in developing a national health insurance. Indonesia had a fragmented system of health insurance system, and at the beginning, Indonesia start with the targeted system, insurance system, especially for the poor and the pregnant women. But at the beginning, 40 years ago or 45 years ago, the starting point is for the government official and the military and the police. And then gradually this is expanded, and especially in the ASEAN financial crisis in the 1998, we start to provide social safety net for health. So using this historical perspective, we trying to expand the coverage, and then since on the 1st January 2014, Indonesia integrated all governments managed system, all government health insurance system into the single national health insurance system that is managed by a single body. We call that Social Security Agency for Health. So this is not easy because before 2014, the central government having the national system, the local government in Indonesia, we have 34 provinces, and we also have like 550 regency on the municipality of the city, having their own system. So starting 2014, we trying to integrate the system, and we targeted in 2019. We achieve like universal coverage. This is the dream at the time, and then the focusing for the curative care. But for the next, Indonesia should be focusing on universal risk coverage, and the future is universal cost coverage. This is the dream from the curative care, preventive care, and then the end is the promotive care. And after 8 years of implementation of the national health insurance system in Indonesia, I think we can say that the system has a good progress, but remaining many challenges, especially for improving coverage for young, healthy, and those working in informal sector, as well as how to ensure the financial sustainability. When we start, we still have 48 million people still uncovered. This is most likely the young, healthy, and working in informal sector. Because for informal sector, we call that this is self-enrolled member, they should voluntarily to register and pay the premium. But I think under the current system, Indonesian National Health Insurance System heavily relies on the government subsidies. More than half of the members are subsidized group. There is co-financing that the government subsidize for the poor and the poor, and also the local government provide the subsidy. So under this condition, that the issues of the national health insurance system in Indonesia is about the financial sustainability. So based on this, maybe this is the concern of the many people in the developing countries. Yes, the national health insurance system is massive program, very huge spending, but what is the impact? So this is also in Indonesia, maybe 5 years ago, there is this very how to say, a person from the Ministry of Finance that has tried to push how to make the system sustainable, while the Ministry of Health focusing more on the service delivery with less concern on the sustainability. So this is like the two stakeholders that not synchronize views. That the Minister of Finance was concerned with the subsidy, no budget, inefficiency, deficit, and the Minister of Health was also talking about the human right on health issue. Health is so important, protecting life and human being. So at the beginning of the implementation, there is like the two sides of the stakeholder different concern. But both aspects at the different language. However, the recent year, there is a more mutual understanding between them that the national health insurance system is one of the milestones for Indonesian development that has contributed to improvement on poverty, inequality, human capital, and the productivity. And therefore, the national health insurance system in Indonesia is becoming more accountable and more impactful. That I would like to little share about some evidence how the system can contribute the impact, with the short-term impact and the long-term impact. So based on this, I hope based on Indonesian experience, the Pakistan maybe can learn about Indonesian experience. So this is just the rapid assessment on impact of national health insurance on access, inequality, and the poverty. The first, I can say that the national health insurance improve access to inpatient care, especially for the low-income group. The blue graph is close to the diagonal one, the diagonal lines, meaning that when the national health insurance system access is more equal. So this is one of the simple thing that this is for exercise for using the household data. We're trying to calculate the Gini, or not Gini, is like the Lawrence curve of the access. But the second thing that the many people, especially in the Ministry of Finance, that believe that the national health insurance contributed a lot for the poverty alleviation. So this is myself who trying to provide the evidence, rapid assessment. At that time, many people is having the difficulty to provide the evidence to convince Ministry of Finance that this program is good and that the government should invest a lot on this program. And using the micro-simulation framework, we found that National Health Insurance Program saved almost 1 million people a year not being poor, because they are covered by National Health Insurance for their medical treatment. I think this is most of the developing countries. When you experience illness or getting the medical treatment, getting the inpatient, you have to sell everything. Sell like maybe your car, maybe your life. But by the National Health Insurance system, we provide the protection for those who are not poor, being poor because of the medical treatments covered by National Health Insurance system. Moreover, the National Health Insurance system also protected around 15 million poor people from worse condition, as the poor can access health care without any payment. So, under the Indonesian system, some part of the people are subsidized by government. The formal sector, government official, private company have to pay premium, and then informal sector, those who are working in informal sector have to pay monthly. So this is the condition that our system within the short run can provide those financial protection for the people. So what is the impact for the long term of the national health insurance system in Indonesia? We also estimated a lower impact of national health insurance on the human capital, proxied by the life expectancy and the productivity using the sum econometric model of the least square and also the instrumental variables. So this is just the little mechanism transmission, how national health insurance system can improve the socioeconomic welfare. So this is JKI, we call the Jaminan Kesehatan Nasional, which means the national health insurance system in Indonesia, because having this membership, you can freely access to health facility. If you have the access to health facility, your health quality improve. If your health quality improve, your human capital improve, and then at the end, this will support the sustainable economic growth in Indonesia based on the new growth theory, and that mentioned that the human capital is becoming the sources of the sustainable economic growth. So this is just the simple mechanism how the national health insurance system can improve access, improve health quality, improve human capital, and at the end, and in the future, will be the sources of the sustainable economic growth. So this is just the simple thing. Maybe, this is popular, but I hope that you are also familiar with some of the regression, that our estimations confirm that household with the national health insurance have a better access to inpatient and outpatient care compare those having the other insurance. And looking at using the topic regression, also confirmed that household with the national health insurance have a lower medical treatment, is more comprehensive treatment than those without any national health insurance. So this is just showing that national health insurance is improving the access and also improving the quality care. So in the term of the life expectancy as the human capital, we were trying to use instrumental variable comparing with the life expectancy. This is just technical one, but why we use the instrumental variable to omit the endogeneity bias. This estimation is confirmed that 1 percentage point increase in patient will increase life expectancy by almost 11 months. But 1 percentage point increase in outpatient will increase life expectancy by 2.5 months. We use, this is the panel data of the provincial level in Indonesia. So we use the long, the periods of combining the time series and the cross-section this panel data. So based on this, we can confirm that national health insurance improve the access to outpatient and inpatient, and outpatient and inpatient will improve the life expectancy. And the end, this is my estimation, economic estimation, that what is the relationship between the life expectancy with the productivity and the log PDRB per capita means that income per capita. This estimation also confirms that 1 year's increase in life expectancy will increase the productivity measures by income per workers by 7.1%. So this is just, I would like to show that this is this evidence is to say this that evidence that we provide can, how to say, can convince the Ministry of Finance that spending the money from the national health insurance is not a cost, but this is investment from the future. So the previously Ministry of Health could not provide the strong evidence to convince the Ministry of Finance about this system. So by providing this some hard evidence about the evidence-based policy, so Ministry of Finance is very convinced, and then they are very eager to support this system. So this is just remark for Indonesian experience. Of course, the national health insurance in Indonesia relies heavily on the government financing, that 58% of the members are subsidized group, 15% are still uncovered by national insurance that we call as a missing middle problem, concern on issues of the financial sustainability. But for developing the national health insurance, needs the mutual understanding from the both health authority and the financial authority that investing on health is not cost, but investment for a sustainable future. Therefore, we need a strong evidence base for the accountability of the program. We, at the university, we have to provide easy evidence, quick assessment to convince that national health insurance program is very good thing. National health insurance has contributed on reducing poverty, expanding access to healthcare, increasing human capital through the life expectancy, and the improving income and productivity. But for the end, this is my conclusion, that the expanding universal health coverage or national health insurance system is very long journey, need a lot of resources, but the important thing is a strong commitment from the stakeholder. I hope that this Indonesian experience, maybe Pakistan or other countries can learn from the experience from Indonesia. And if you would like to deeply explore about the national health insurance in Indonesia, you can go to the Agustina et al. But I'm also the co-author from the Lancet, the paper. And in the end, thank you very much. I'm very welcome for the question from all the audience. Thank you very much.
Thank you, sir, for your dedication and efforts for explaining the situation in Indonesia. Now the forum is open for questions.
Hi, Dr. Dathanto. And we had a very explained and detailed view from your end regarding the coverage and determinants affecting the national insurance system in your country. You just said, I've got one query, just a question, that you said that 48% of the population is covered under the health insurance. Am I correct? Probably. How much percentage of the population was undercovered under the national health insurance?
No, there is a 85%.
85%, all right.
Yes.
So, what are the determinants do you feel that may increase further the coverage of insurance system in your country, further to 100% probably? It's a good number.
Yes, there's still a challenge how to expand to having the 100% of the populations, because the problem is the young, healthy, and those working in the informal sector doesn't want to join the program. Our government is trying to, there is no foolishness, how to force them. But no, we're trying to engage with some, for example, like maybe you heard about the project or the tracks, like the motorcycle taxi. The government or the Social Security Agency for Health trying to collaborate with them, and then those were becoming the rider of the motorcycle taxi. They encourage to join this system. But I think this is not very easy, especially many of them can join the program, but the problem when they are in the system, maybe only 1 or 2 men to pay premium, and after that just not paying the premium. That's why the problem is the sustainability. The first year of the system, in the first years, there are very huge deficits, but now it's gradually the system is stable, even though it's still the deficit. A year deficit is almost 1 billion US dollar per year. Still, that's why the Ministry of Finance always pay attention on this system, because this is one of the new the new burden from the national budget, because the government have to provide at least sometimes 1.5 billion US dollar, sometimes 1 billion US dollar. But no, the government trying to find how to finance this deficit using, we call that the sin tax, or no, it's called the health tax. We're trying to use from the tobacco tax, and also the government trying to find the sources from the sugar, the beverage with the sugar, and then we're trying to provide the taxing of the beverage. So there are many things to do, but this is good progress in the term of the public health policy, but in the term of the financial issues, our system is not yet sustainable. For me, I'm the economist, but no is trying to bridging the perception of the Ministry of Finance and also the Ministry of Health. So maybe I can speak with the Ministry of Finance, because they guess that I know well about the health system, but in the term of the Ministry of Health, they believe on me, because I already published in the Lancet. They believe that I know a little bit on health issues, so they work me. So this is the challenge in Indonesia.
Thank you very much, Dr. Dathanto. It was an extensive, analysis of the system and determinants affecting the insurance. You done very well. and we really took very good advantage out of that. Thank you very much. Thank you very much. My name is Dr. Bilal Siddiqui, Faculty of Public Health, SZABIST.
Thank you, sir. Okay.
I have a question, ma'am.
Okay, please
Can I
go
ask?
ahead.
Greeting to all the presenters from Indonesia, Iran,
Bangladesh.
and Bangladesh. I'll take this forum as an opportunity to ask, as a student, as public health experts from the Indonesia, Pakistan, Iran, and Bangladesh are here. We, as a student, what are the opportunities for a student that are recently passing out as a public health graduate? What are the opportunities in Bangladesh? How do you cater students in Iran from this field? And what are the future endeavors for us?
Is it specific for Iran? Shall I go ahead?
You all can answer one by one, sir. So Amir Hussain, you can answer it first, please.
Okay, thank you very much. I'm so glad that the future leaders of global health are among the audience today. One specific privilege that the current generation of students have is the vast of resources you have in your hand. We cannot imagine the degree of change and transformation we have been experiencing in the course of last 2-3 decades. The amount of data which is available, I remember when I was a medical student, when I wanted to search something, I had to stay in the queue and book for the Medline to give me some papers after 3 months of publication of this sort of thing. Now you are in the possession of vast amounts of data and resources which is available to you very, very cheap and accessible. That's the first privilege that you have. The second privilege that you have is the international regulations and tools and toolkits that you have handy. The degree of international wisdom and experience to tackle with the public health challenges gives you a great privilege and big responsibility. Just look at the COVID-19 experience. The whole sequence, the whole genetic sequence of the COVID-19 virus was identified less than 2 weeks. And then after a year, we had an effective vaccine. This is revolutionary in the entire history of public health. So we have reached at the edge of science, data, information, and access to tools, and more importantly, the partnership. Now, the partnership, the meaningful partnership, and the meaningful relationship between the different institutions. So you can sit in Karachi, listen to my colleague in Indonesia, to me in Tehran, and to many people in the remote areas of the world. And this brings you the opportunity to learn, share experiences very vividly and at a good time. So my suggestion to you is, building upon these vast resources that you have and the luxury that you have, you need to, my recommendation is you need to make a good network, a network in which the science, literacy, and being in the leadership positions of public health is not anymore just doing research in labs. It's the network upon which you can share the experiences and the common understanding of the difficulties of the public health and global health, and then move ahead with these experiences to build a better world. I'll stop here.
Okay. Thank you, sir. Thank you, sir, for your suggestions. Dr. Tegi, would you like to answer?
Yes, I think so. One of my suggestions for the student from the public health, and I think this field is becoming promising. I think it's not only in Indonesia, all over the world, it's becoming but the promising field in the term of I think remuneration or the benefit or whatever. But I think that the important thing in the current situation, and for the student, for the public health, that you must be open-minded student, and then not only focusing on the public health, but you have to learn another field. Learn another field is that open-minded to know about the another field or more interdisciplinary thinking. As I myself, that I'm the economist, and then and the time in the 2014 I decided to go to the head economist, and my decision is correct. And not many economists in Indonesia having the concern on the health or public health, but now in Indonesia I'm becoming one of the I can say that I'm the one of the leading health economists in Indonesia, and that have many collaboration with the public health people. So my suggestion as the student is be open-minded and be collaboration with the other field. So making you better understanding what's going on in the world. Thank you very much.
Thank you, sir. Thank you for your time. Now, honorable guests, faculty, students, and attendees, the conference has come to an end. I would like to call upon Dr. Samira Ali for a vote of thanks. She is currently working as Assistant Professor, Program Manager, Academic Head of 2 programs, MSPH and BSPH. Please, Ma'am Samira.
Salam and good morning to all of you. On behalf of the Department of Public Health under Faculty of Life Sciences, I would like to thank the distinguished speakers for their enlightening presentations and for making this conference very meaningful and informative. Public health, through the Sustainable Development Goals, aims to eradicate every form of extreme poverty, including the lack of food, clean drinking water, and sanitation. The objectives of the conference were to bring in together the public health community to discuss the role of poverty in the poor health situation of the populations like Pakistan, Indonesia, Iran, and Bangladesh, especially in the post-COVID scenario. We are grateful to our honorable speakers, Professor Dr. Fareed Nad, Professor Dr. Awazariman, Professor Dr. Inayat and Dr. Assanil Khan Wazir for their valuable time and their physical presence. We are extremely thankful to our virtual online esteemed speakers, Professor Dr. Mushtaq Chaudhry, who joined us from Dhaka, Professor Dr. Amir Hussain Takian, who has joined from Iran, and Professor Dr. Tegu from Indonesia, for taking out their precious time and enlightening us on their experiences and work on this topic of immense importance. Department of Public Health would like to express their gratitude to President Madam Shahnaz Wazir Ali and Professor Dr. Altaf Hussain Mukati, Vice President Academic SZABIST, for taking out their time from their busy schedules and attend this 2-day conference. Dear Madam, your continuous support towards the Department of Public Health provides us strength and motivation to work harder and with more dedication. Our thanks to Dr. Kashif Ali, our HOD and Dean of Life Sciences, who made this event possible and without whose support this event would not have been possible. Especially, I would like to express our deep gratitude to Honorable Professor Dr. Mehtab Karim for opening a new window of opportunity for making this conference a success for the Department of Public Health. We are also thankful to our dear students whose presence adds a significant value to this event. We hope you have learned and you have now some research ideas in the field of poverty and related issues. A special thanks to all our organizers from the Department of Public Health and from the Department of Biosciences, without whose hard work this would not have been possible. Thank you.
Madam Shahnaz Wazir would like to share a few words with her.
Maybe it's just a little more than 2 words. First, I would like to thank the students. You have been marvelous. You can give yourself a round of applause. I really find your attention, the seriousness with which you listen to the various speakers, the questions, the thoughtful questions that were put, and the remarkable array of specialists, outstanding speakers that you had an opportunity to listen to their professional experiences, their work, their analysis, the data. All of this has been a remarkable conference. I do want to say this, that I think Dean Dr. Kashif Ali, you and your entire team has done an excellent job. I have not seen such a good conference in SZABIST for a long time. I know that this has taken a great deal of effort. I want to thank Dr. Karim especially for the international connections with the professors from Bangladesh, Dr. Mushtaq Chaudhry, outstanding presentation by Dr. Amir Hussain Takyan from Iran, an excellent presentation also from Indonesia. We had an array of universities that were represented here. There were outstanding speakers from various Pakistani medical universities, from institutions, from the Health Services Academy, Dr. Fareed Nad, and many others. I will not take your time because you've been sitting very patiently since the morning, and it is really, I think, excellent group of students here at SZABIST. We're very proud of each and every one of you. I hope that these 2 days have broadened your own mental horizons about the field of study that you have chosen, whether it is in biosciences or it is in public health. You can see what an amazing set of opportunities that you have, both nationally and internationally. So I hope that you will all take serious interest in further, perhaps in finding an opportunity to listen to these presentations, because they're all recorded. And this would be my request to you, Dr. Samira, and your other colleagues, that since everybody was not able to attend the conference, that the recordings should be made available along with the multimedia presentations and the data sets, because there can be no better learning experience than to sit right here and be able to listen to professionals, top world-class professionals from different parts of the world, and especially from countries that are relevant to us. Bangladesh is very relevant for Pakistan, so is Iran, and so is Indonesia. These are 3 countries that have changed and transformed the health indicators in their countries, connected to also women's empowerment indicators and health outcomes. So I just wanted to take a minute or so to thank everyone, and to particularly commend the students for their interest and for their remarkable, what should I say, deep interest, I think, in the subjects that you heard, because usually it's a pretty long session. You've been here since 9 o'clock in the morning, and it is almost getting to be 2, so you've been here for close to 5 hours, listening to, I think, a very remarkable set of speakers with a lot of information. Thank you very much. Thank you, Samira. Thank you to the entire organizing committee as well. And I do hope that we will have the linkages, Dr. Kashif Ali, with these universities where we've had the chance to listen to their deans and to their professors, because I think there may be opportunities for you to do research, to link with them, to see what their programs are, and to learn more from these countries. And maybe, who knows, one day we might create a group and you can go to Tehran, or you might create a group and you can go to Bangladesh to actually visit their health and public sector systems. Thank you very much.
So the conference has come to an end. Faculty, kindly facilitate and accompany our honorable guests for lunch. Proceed towards room number 6. Students, you are requested to collect your lunch boxes from room number 13, maintaining the decorum. Thank you all for your attention and cooperation.
Thank you very much. Bye.